Afternoon, everybody. Lovely to see you all. Welcome everyone to the meeting of the Leicestershire Health and Wellbeing Board. I'm Paul Harrison, Cabinet Lead Member for Health and Public Health at Leicestershire County Council and new Chair of this board. This meeting has been broadcast live via YouTube and it will be archived so that you can see it and view it afterwards. Please turn your microphone on when speaking and turn it off afterwards. I believe we just have one apology. I believe it's Mr. Charles Pugsley. Thank you very much.
Yeah, that's correct. Mr. Pugsley has given his apologies.
Thank you so much. The appointment of the chairman. This item is just to note that I, Mr. Paul Harrison, CC, am the Leicestershire County Council Cabinet Lead Member for Health and Public Health and am therefore the new chairman of the Health and Wellbeing Board. Minutes of the meeting held on the 26th of February 2026. Myself, I was not present at the previous meeting, so please can I have a proposer that the minutes of the meeting held on the 26th of February are as read, confirmed and signed. Thank you very much, Mr. Squires. Do I have a seconder? Thank you. Fantastic. So item number 3 on here is to advise of any other items which the chairman has decided to take as urgent elsewhere on the agenda, and there are no urgent items. Number 4, item 4 is declarations of interest in respect of items on the agenda. I need to mention that I'm a member of the local patient participation group, so I'll be declaring that wherever relevant to agenda items throughout the year. Are there any other interests to declare? Mr. Kaufman.
I think I ought to declare my son works in this building somewhere for the NHS.
Okay.
And I'm here as a district council representative.
Fantastic. Thank you very much, Mr. Kaufman. Are there any other? Sorry, Michael?
Yes, I'd like to declare an interest due to my employment with LPT.
Thank you much. I think we're there. Okay. Position statement by myself. Hopefully copies of my position statement have been emailed to you and a version is also published on the council's website. I'm not going to read everything else on that obviously, but you've obviously got it in the post. A couple of things I just wanted to pick out really was there's the changes to just to reinforce the cabinet portfolios changes. So I'm the new cabinet lead member for health and public health. Councillor Squires here is now adult health, and Charles Pugsley remains as children's health. So no change there. At the board meeting on the 25th of February, Matt Gaunt, Chief Finance Officer, Integrated Care Board, was elected as Vice Chair for a period of 2 years. So very welcome, Matt. So I'm going to move on a little bit so that's the position statement. So on here. Before we move on to that, I just want to pick up a few things from the previous minutes. We've all just agreed that they are that they're okay. On the previous minutes, some key decisions were made. One was obviously to elect Matt, which is great, that's been done. And the approved creation of CYP-based group. I don't want anybody to sort of go into a lot of detail because obviously I'm new to this role, but can anybody tell me if that creation of the CYP-based group has been started or?
Yeah. Yes, it has, Chair. I know Sean, as my children's lead, is on leave this afternoon, but I know they met, or that's all Sharon, I'm sure that group met a couple of weeks ago for initial meeting, I think, wasn't it? So that's up and running.
Thank you so much. That's fantastic. So there were some changes to the Best Start for Life governance. Is that anyone follow up on that one?
Well, I think that's the same thing, isn't it? Because so that was about changing the governance so that the subgroup rather than the children's partnership kind of took forward the actions in the strategy around Best Start for Life. So one and the same.
Okay, fantastic. Thanks, Matt. Approved the establishment of the JSNA group. Okay. Anyone know what JS? No. Okay. It's okay.
Strategic needs.
Fantastic.
Yeah, it's the joint strategic needs assessment.
Thank you.
A new iteration of that is underway and a steering group is currently being formed. So we'll have an update hopefully at the next meeting.
Wonderful. Okay. Thank you so much, Abby. And approved the creation of a county-based team. So does that ring any bells? Is that okay?
Yep, and that is the the paper out last round talked about sort of almost the fifth beetle, if you like, in terms of the subgroups of the Health and Wellbeing Board, putting in place the county-based team of workers across health and public health and social care, and that was meeting informally before, but now meets formally. For information, we've pulled it together with a David Williams-led neighbourhood health implementation group. So we have a bit of a joint meeting, which includes kind of progress on neighbourhood health within the NHS, and then the place-based more general stuff around the health and wellbeing strategy as well. So that's up and running too.
Thank you so much, Mike. Perfect.
Looking good for me. I don't think I've failed anything there.
Feel like good news. This, developing neighbourhood plans is that something that you're going to, Mike, or is that I picked up Abby again?
And that's part of the work of the neighbourhood place-based group.
Okay.
I think there's some information in the position statement regarding the neighbourhood implementer site.
Okay. Thank you.
Thank you.
Obviously, there's one that's going to be around for a while. I think the improved hospital discharge performance. I think that's going to be a recurring theme. I can't see. It's always going to be something that's there. So yes, thank you very much. Let's just pick up really from the last time. So we're going to go on to now item number 6, the Joint Health and Wellbeing Strategy Progress Update on Staying Healthy, Safe and Well. So this report provides an update on process in relation to the Staying Healthy, Well and Safe and Well priority of the Joint Local Health and Wellbeing Strategy 2022-32. The report is going to be presented by Joint Chairs for the Staying Health Partnership, Mike Sandys, Director of Public Health, Communities, Law and Governance, Leicestershire County Council, and Ed Coverley, Chief Executive, Milton Borough Council. I hand over to you.
Yeah, thanks, Chair. Just to say, really, just to reiterate what you were saying, this is our update report on the work of the Staying Healthy Partnership, one of the subgroups of the Health and Wellbeing Board, which has got the job card of leading progress on the Staying Healthy, Safe and Well priorities of the Joint Health and Wellbeing Strategy 2022 to 2032. Report outlines quite a lot in there in terms of the appendix. There's been an awful lot of progress made. Thanks to Ed for his co-chairing. To kind of illuminate it a bit, rather than us go through the report, we've invited Natalie and Jenna and Holly and Francesca to pick up on a couple of key priorities within the work of the Staying Healthy Partnership, one of which is around health and all policies and health and all policies, and the other is kind of food and whole citizens approach to food. So Ed, I don't know if you want to say anything extra, or whether we let the others impress everybody.
Yeah, no, and they certainly will, because they've got a great deal of work. I think Mike and I are often the guys who kind of take the credit for this work, but it's really built on the work of a whole raft of other colleagues. And we're going to hear from a number of them say this is still only the tip of the iceberg. There's a whole raft of other groups of colleagues who are doing great work around healthy workplaces. So there's the Work Well programme, which is sitting underneath this, and just looking at some of the stats that are set out in your report, you can see the impact that's being made in terms of investment and then outcomes being delivered for residents. I think 1,200 participants have been through that Work Well programme. Hundreds of properties are being supported in terms of our Healthy Homes programme as well to become more energy efficient. So there's a whole raft of other programmes, but we did want to, as Mike said today, just create a bit of a spotlight on a couple of areas of particular focus this year, and far better to hear from them than from us. So Chair, with your permission, we'll hand over to our colleagues to take you through the presentation. Thank you.
Please. Thank you.
Good afternoon. To introduce myself, I'm Jenna Parton. I'm a public health specialist, and I lead on the wider determinants of health in the public health team. And this is Natalie. We'll start you off with the presentation slides, and she is a strategic lead within my team as well. So we're going to go through health and all policies and healthy placemaking today, and let you know about what the progress that we've made against the priorities and objectives that we've got within those pieces of work. So thank you.
Thank you. Next slide, please, Abby. Just to kind of share with you we're here to provide an update around the health and all policies work to date, and obviously the commitment showing on screen now that essentially we're working towards embedding health and equality considerations across decision-making processes in line with the Health and Wellbeing Board priority. Next slide, please. So the aim of health and all policies is to ensure that health is considered routinely, not separately, when policies and strategies are in development and when they're being progressed. And this reflects the evidence that many of the most significant influences on health sit outside of health services, as we all know, including things such as housing, transport and the environment. The approach, therefore, focuses on making better use of existing levers across the system, so supporting more informed decisions to improve outcomes and reduce inequalities over time. Importantly, as sets out in the report itself as well, this supports the earliest consideration of impacts, so that we're there helping to reduce the risk of unintended harm and improve resources used across the system and avoid avoidable pressure on services later on as well. Next slide, please. So this is how we've kind of realised that. So that's kind of a wider background to health and all policies, essentially, you know, embedding health considerations as work is being shaped. To realise that and how it would work best for Leicestershire, we introduced a structured programme at the county council level. So that combined both practical application alongside a tiered training package that's available for all staff. As part of that commitment to health and all policies for Leicestershire, all cabinet, anything going to cabinet and scrutiny now routinely has health considerations embedded within that, so that people are being asked to kind of reflect as part of their work as they're developing those strategies, those proposals. Are there any impacts to health? If there are any negative impacts, how can we work together to mitigate those if possible? And if there are any positives in terms of how health outcomes, how can we maximise that as well? So that's now routinely on all cabinet and scrutiny reports. Training's been a really key part of that. So it's kind of one thing having it on the cabinet and scrutiny reports, but to bring that to life, obviously we've worked really closely to set up an engaging training programme that's available to all different members of staff at different levels, so that we're raising that organisational awareness as well around wider determinants and how it links to all services and policies as well. So far we've had over 260 staff that have been engaged in this training. That's at all different levels, and it's been very much a targeted approach as we've been rolling it out in-house. So we've been working with key departments to progress this piece of work as well. So we've been kind of plotting the training against the key strategies that are coming out at the right time, so we can really kind of make that work as beneficial as possible. So alongside the training, we're also seeing evidence of an increased integration of health considerations across all different policy areas, including local plans and transport strategies. So supporting earlier and more informed input into those decisions as they're being made. Most importantly, obviously, this moves the considerations of health upstream. So it helps to identify those potential impacts a lot earlier and reducing the risk of unintended consequences, and improve the overall quality of the decision-making processes as well. We're doing it in line with everyone. So just to really support that more coordinated use of health evidence as well across different services. So making better use of existing resources and reducing duplication as much as possible as well. The model was designed to work within existing processes, so to ensure that it's the most practical, proportionate possible to implement, really. Next slide, please. So in terms of impact, health considerations are becoming more consistently reflected in decision making. We're working really closely with lots of different departments. We've made some really great progress, especially with transport colleagues. So we're really happy with that. That we can see there's a stronger focus on wider determinants and reducing health inequalities, utilisation of health data as well. And we're working really closely with lots of different departments. So we know that we've got that kind of engagement is building as well. The approach is now extending beyond the county council. So we're going to share the model with district councils as well, starting with Blaby. Starting with North West Leicestershire and then later Blaby. So they'll be launching towards the end of this year as well. And that's really important given the statutory responsibilities that sit at a district council level in terms of planning and housing. So they're really key levers in terms of health inequalities. So we're really keen to share that work as well with the district councils. We've had a lot of interest working with the VCSE sector as well and sharing that training. Yes, sharing that training and looking at how we can use health impact assessment again as a tool within that sector. So that's been really key as well for this year. As part of this work, we've had some national recognition around the Health in All Policies Leicestershire approach. It was described as gold standard by the National Health in All Policies Network, and it was selected for inclusion in the Local Government Association guidance as an example of best practice at local authority level. So again, we're really proud that of that work, and we thank the board for its commitment and and kind of focus on this area. It's been really, really key in shaping that work. So taken together, this shift is now we're shifting towards that earlier, more joined up decision making, and again, really just focusing on reducing the risk of avoidable impacts and pressure on systems later on. So in terms of next step, the focus is again building on what's already working well, and the staff feedback that's shown on the board to the right hand side is just kind of key in showing really how we're adding that health lens to day-to-day work. It's kind of business, it's becoming business as usual now, which is really, really, it's good. It's not an add-on, it's not an additional piece of work. We've integrated it very much into the kind of processes that are already in place in-house, and we're sharing that knowledge now with the districts as well to make sure it works for them in a way that's bespoke for the districts as well. So again, thank you to the board and the Staying Healthy Partnership for maintaining focus on this important area of work. Thank you. I'll hand over to Jana.
Thank you, Nat. So the next focus is a part of health and all policies really, but a really, really important part. It's how we might work together to influence, and how we have been working together to influence embedding health within planning policy and everything that surrounds that as well. So we turned it under healthy placemaking. I think from previous meetings that struck a chord with some people and said, actually, I know what you mean now. So healthy placemaking is around working together to shape healthy places, to create strong, connected and resilient communities where everyone can thrive. So how can we build our new places to fit in with our existing places, create cohesion, create new opportunities to be healthy, and support people to continue to be healthy as well. So it's really, really a key part of health and all policies that we've been working on. Next slide. So healthy placemaking aims to transform the way the built environment is designed and created to ensure our places support and promote the health and wellbeing of residents. I wondered actually, I've been having a think as we sit here, could we skip to the next slide and come back? I think it tells a better story actually. Thank you. So as a sort of segue from the health and all policies, and the spoke about the health impact assessment Natalie mentioned, that's a key tool in health and all policies. It's a rigorous, objective, systematic tool that helps people consider the health impacts of their project or programme or proposal. And we've done pilot work across the county with different districts to look at how we embed health impact assessment requirements within their local plans. It's been no mean feat. We've had lots and lots of local plans come together at all the same time. That wasn't the plan when I started in my post in 2021. We've had numerous delays for different things. We've actually had probably really 6 come through at very, very similar times. And we're now working with the 7th Charnwood that was slightly further ahead in anticipation for their new local plan. So this doesn't start, this is very cyclic. And what we really wanted to do is to embed health impact assessment requirements in policy, because that makes that a much stronger focus for people and developers and our local planning colleagues. So set out the policies that we've helped draft, set out expectations for developers where appropriate to assess and address potential health impacts. And as you saw on the earlier slide, we're not just looking at negatives, we're also looking at possible positives and how we can help exacerbate those positives and make people be able to perhaps access those on a wider scale we possibly can to make things accessible. And we've also undertaken strategic health impact assessments. So to try and pick that apart, we've got asks of developers to do health impact assessments on a planning application. And also as a team, we've looked at the policies themselves and we've applied that health impact assessment template as well. Got a quick snip of it on the top right hand corner. Looks a little bit like a risk assessment. So it would go through things like influences to health behaviours, environmental impacts, economic, social, community impacts, and looks at the scale and the likelihood of that the proposal to have an impact on those areas and on who and when. So we can make these informed decisions. As a team, we've created local data packs to help people understand what the area, the health profile is within the area, and make that really informed decisions there as well. And we've also run multi-agency workshops. So as many people as we can on a virtual or in-person table and got that sort of feedback as well. And we've worked so the voluntary sector to get people to perhaps tell us what's actually happening on the ground, not just what we can see in the data, but how people feel about their local area. And that's been supported by close working with planners, shape locally relevant health civic policies. So they really reflect that district area. But now we're proud to say that all the authorities we work with do have the health impact assessment requirements within that local plan that will be going to examination. So that's exciting times, and we can start to make that come to reality. And what do we do with those is, I think, what might have done on slide 7, if we can hop back, is my ask to the Staying Healthy Partnership or the year before last, I think, was that's brilliant. And we've got that in local plan policy. What does good look like for Leicestershire, and how do we use these health impact assessments and this policy to put that into reality? So we had a healthy placemaking event in February, which had 50 partners from across the different sectors, and we looked at Staying Healthy Partnership and got a good cross section of people that attend, and we looked at how the built environment could help improve health and reduce health inequalities, and that's a real key thing of health impact assessment and health and all policies, and how we might identify shared priorities for action. So what does good look like? And as part of that, we've got a healthy placemaking forum that we put back in place that will focus on key topics. We can all get together and look at how we're addressing certain parts of the built environment, but on a common thread. Might be slightly changed due to the inequalities or health profiles of the area, but we're doing the same things and we've got the same ideas and we're sharing best practice. So feedback was overwhelmingly positive. 97% reported the event met or exceed expectations, and 94 agreed it was better informed work and decisions. So it was really, really positive. I really, really enjoyed the day, and I think there's some great feedback on that. And we created a little infographic and pictorial to start to unpick the conversations. And then last slide. No, hopefully not. Sorry. Just share with you a picture of the day that we had, and to quickly go through the impact that we've had so far and next steps, just to summarise. So health considerations are increasingly embedded in the planning processes, but we also work on things such as the national significant infrastructure projects. So those sort of national projects that come through around transport, connectivity, etc. And that's done some really great work there, going to examination recently and advocating for health considerations to be made in a proportionate way. And a robust assessment as well. Proactive engagement. We've actually got developers coming to us before the local plans have been adopted, saying we've seen this in a draft. Could we work with you? What does this mean? How can we do it in the way you'd like? We'd really like the Leicestershire templates to be used for health impact assessment. And the feedback has been they found it really positive experience working with us. It's not something we're marking they're doing. It's a collaborative experience. That's gone really, really well. And building a shared understanding of healthy placemaking has been really, really key, and what that means and what we want to achieve. And that day really sparked that for future next steps. So the next steps for us is to support the examinations as the local plans go through, with the health impact assessment requirements within that, and look at how we shape places that people feel part of, connected. They can be physically active, and also the local food environment there, I suppose, as a segue into your I haven't got notes, I didn't even write that down. So thank you very much.
Somewhere. Okay, talk amongst yourselves.
Segue doesn't work now. Been too long.
Yeah.
So proud of you.
Oh, thanks, Abby. Yeah, so there was a nice segue, but I lost the moment. Hi, everyone. I think I know quite a few of you, but Holly Hutchinson, public health specialist within Mike's team, and myself and Francesca will cover the whole system's approach to healthy weight food nutrition and gold sustainable food places in terms of our commitments. Apologies in advance for food related puns. We can't help ourselves, it just happens. So next slide, please, Abby. So this, just to remind the board on the commitment, so it's we will continue to strengthen and expand the whole systems approach for healthy weight food and nutrition, including the role of physical activity by engaging the most appropriate stakeholders. Next slide, please. So the whole systems approach really recognises that food and healthy weight are shaped by a complex interconnected system rather than lots of kind of individual isolated behaviours and actions. So our approach brings together partners across our system, so local government, NHS organisations, VCSE, academia, along with strong kind of resident insight and engagement. So we have a clear governance structure in place. We have a steering group. We have 4 subgroups that are helping us drive our delivery. And the aim is to really enable long-term sustainable change and reduce health inequalities through that coordinated effort. But it's difficult and it's really challenging. And if any area had kind of solved it, we would just be copying what they do, but nobody has yet. So we're hoping that together we can kind of really work with each other's strengths and push this forward. So our approach really recognises that the whole is greater than the sum of its parts, but we all have a really important part to play in this, and that we can't do it alone. We have to work together on this, or else we just won't succeed. Next slide, please. Thank you. So this slide kind of shows our progress to date, what we've been doing over the past 12 months. There was guidance from what was Public Health England on how to adopt a whole systems approach to obesity. So we took that and we broadened it out really, because we have quite a, I guess, mature work around more kind of farming food sustainability. So we've kind of amalgamated that with our work on healthy weight to create a whole systems approach to healthy weight food and nutrition, apologising that it's a bit of a mouthful. In terms of what we have done significant stakeholder engagement to establish our shared priorities, and on one of the next slides we'll show you what that looks like. But this has included 3 stakeholder workshops and quite a lot of one-to-one engagement with system leaders. We've also involved our residents and VCSE partners to ensure that the priorities that we have really reflect what the residents need and what the residents want moving forwards. We do have 4 cross-sector working groups, and they've been established to take forward those priorities that we've got. And we've also got agreement reached through the Staying Healthy Partnership to have a strategic plan for food, which will kind of be our delivery plan. So our focus now is really moving on to getting that shared commitment on actions, moving into delivery, and then maintaining that momentum. Please. So apologies. It's not very clear and it's also really messy, but this is what we're calling our local messy map, and it really illustrates the complexity of the food and healthy weight system. This is not easy. This is our local version of the foresight map. If you've not seen it, I recommend going and having a quick Google of the foresight map, because that shows what it's like at a more national level. But this is our local level that we pulled together with partners through those stakeholder meetings that we held. And for this one, it highlights the interconnections between the factors such as education, accessibility, advertising, active lifestyles, and social influences. And these are our local system priorities, and they're covered by our 4 working groups. We do acknowledge and appreciate that these aren't everything that goes towards a healthy weight and food system, but these are the things that as a system, all of our kind of organisations sitting around the table and broader are focusing on, want to focus on. So that's what we're doing moving forwards. And this system approach really helps us identify the leverage points for action and really helps bring together partners so that we can do that coordinated activity. It's important to say that we're sitting here, Francesca and I, as public health, sharing this work, but this isn't our work. Our role here is around convening this and supporting the work, not necessarily directing it or dictating it. That's the joy of a systems approach, and also one of the challenges of a systems approach is that everybody's voice is just as important as each other, and our role is really to hear those voices and bring everyone together on those shared actions. So this slide does give us a bit of a flavour, first one there, of some of the work that's been going on. So firstly, as I mentioned, it's the development of that strategic plan for food, and that's really our central piece of work. So that provides Leicestershire with that clear long-term shared vision. for our local food system, and also helps us kind of evidence that delivery towards the joint health and wellbeing strategy commitment. And also by anchoring delivery to the joint health and wellbeing strategy, it really makes it easier for partners to get that strategic buy-in at their local organisation as well, because you've really got a clear line of sight between strategy, governance and then delivery. And the strategic plan also plays a critical role in our Sustainable Food Places Gold Awards submission, which Francesca will talk about in a little minute. Secondly is a lot of work around academia. So we are public health, so a lot of what we do is driven by that evidence base, but sitting on our subgroups and our steering group as academic partners from the University of Leicester and Loughborough University, or University of Loughborough. But we're also working with them on academic pieces of work as well. So we kind of what's the word I'm looking for? Co-sponsor, co-supervise is the word. A PhD student looking at the perceptions of the National Childhood Measurement Programme and how we can improve that locally. And we're doing work on interventions around reducing ultra-processed food consumption as well. But they also bring with them their wealth of academic knowledge as well that can help shape our work moving forwards. The third element here is resident and VCSE insight. And for us, it's really important that this isn't a one-off. We're learning all the time. We're always having those food conversations, but we're making sure that it's fed in. And that's what the diagram there is. It was some of our teen health colleagues asked children and young people, what does good food look like for you? And sometimes it's not like a full-blown conversation. Sometimes it's just a question, and that we can capture that and make sure that that can help drive our work moving forwards. And then the last element on the slide is a kind of very specific activity that we've been involved in, but there is things that we could have picked. But this one is about looking at reviewing food provision within the short break service for adults with learning disabilities, and then joining up with LPT through the nutrition and dietetics service to see how that we can kind of educate and improve that food provision. I'll pass to Francesca.
Thanks, Holly. Good afternoon, everybody. So I would be taking us through our Sustainable Food Places Gold Award, and just to highlight our second commitment within the health and wellbeing strategy there. We will work together with partners, businesses and communities to achieve the Gold Sustainable Food Place status for Leicestershire. Sustainable Food Places brings together food partnerships from across towns, cities, boroughs and counties across the UK that are driving forward innovation in best practice on all aspects of health and sustainable food. So just a bit of context, if you could move forward, Abby, please. A bit of context for our Sustainable Food Places. Leicestershire was awarded Silver Sustainable Food Place status in 2023, marking an important recognition of the progress that we've already made across the local food system. It's important to emphasise here that the SFP accreditation is awarded to the place rather than one single organisation. And as such, activity delivered by our partners across the food system collectively contributes towards the award. Progressing from silver to gold requires demonstration of two exceptional areas of practice, and this sets a significantly higher bar and aligns well with our ambitions of the whole systems approach, particularly around partnership working, systems change and long-term impact, rather than focusing on specific individual projects. The Gold Award submission process includes a visit from the National Sustainable Food Places team, which provides us with external scrutiny, challenge and validation of our local progress. And finally, it's important to note here that achieving gold is not the endpoint. Rather, it's a mechanism to maintain momentum, embed continuous improvement, and reinforce that long-term commitment to a healthier, fairer, and more sustainable local food system. The focus definitely remains on meaningful system change rather than the award itself, although achieving the gold award will be pretty good. So if we can move forward, please. So this slide just provides some further detail on a number of key programmes that contribute toward the delivery of the whole systems approach and supporting our Sustainable Food Places Gold ambition. So working in partnership with the Allerton Project, a demonstration farm, £109,000 over 3 years has been secured from the Samworth Foundation to support the development of a meaningful engagement with local farmers across Leicestershire. This initiative aims to facilitate meaningful engagement and ensure that a key element of this will be the focus on securing how local food supply chains can be shortened. This programme is innovative, with Leicestershire currently the only place in the country adopting this approach to directly engage with local farmers. Secondly, resident insight continues to be a core component of both the whole systems approach and our GOLD programme of activity. Activities such as local food conversations and the development of a grassroots food plan are enabling residents' views, experiences and priorities to directly inform the local food system and programme and design. This helps to ensure that interventions are relevant, equitable and responsive to local need. Food insecurity programme also remains a key area of focus, addressing both the immediate impacts of food poverty and the wider systemic drivers of such. A working group has been established to drive this work forward and benefits from strong cross-sector engagement with representation from all 7 districts and local food provisions and many VCSE sector organisations. In addition to these programmes, there is a lot of related activity underway across the system and life course as a whole, looking at key moments where we can influence behaviours and have conversations around food, such as from early years through to later life. So, for example, increasing the uptake of the National Healthy Start Voucher Scheme, breastfeeding support, general food access and free school meal uptake. You can move forward, Abby. Thank you. So just lastly, the delivery outlined previously constitutes a significant and complex programme of work across the food system. In the coming 12 months, a core priority will be to maintain momentum and strengthen commitment from strategic leadership and the wider partnership as a whole. Continued engagement at senior levels is essential to reinforcing the shared ownership of the agenda and ensuring that food and healthy weight remain embedded across system priorities. We will also continue to embed resident and community insight into the programme, design and delivery. We'll be building on engagement work already undertaken, as Holly's mentioned, ensuring lived experience will increasingly shape how our programmes are refined, delivered and evaluated, ensuring that activity remains relevant, equitable and responsive to local need. As Holly mentioned, further development of the strategic plan for food will remain a key focus. And in parallel, we'll be working to continue to prepare for the Sustainable Food Places visit in the autumn and the subsequent submission of our application just before Christmas. So finally, effective delivery of the whole systems approach governance arrangements will remain critical to this work. This includes supporting working group activity, maintaining strategic oversight through the steering group and facilitating a biannual partner network to sustain collaboration across the food system. Thank you.
Thank you so much. That's a lot. so well done. Can I open up for questions? Would anybody like to ask a question? Matt? Oh, sorry, Yasmin. Sorry.
Thank you, Chair. I'm Yasmin Sidia. I'm Director of Integration for the ICB. A lot of work has gone on and I can really see and demonstrated in the work. I guess the question is, and I guess this is something not just for you guys, a question for myself as well, as I come into my role as well, about how we stitch this into the neighbourhood sort of strategic plans from a place perspective, particularly to note around the healthy place making as we sort of move forward with the national plan around neighbourhood health centres, for example, ensuring that those, are embedded, that healthy placemaking is really embedded into that, and in the development of that will be really key. And then in terms of the food and healthy weight strategy, I know that it's also a very major part of our strategic plans as well from a ICB perspective. So again, it's just making sure we're stitched into ensuring that the work that we're doing, which is on the other side of the fence often, is very much linked in to make sure that we can support people to sometimes come out of what is very vicious cycles that they get themselves into. So how do we support that? And I think, the bit around the farming community, I think is really good. Something around food wastage as well, which I'm sure is already probably embedded in the detail of the plan. But we know that food wastage is something that, especially around fruit and vegetables, we know is a significant, has significant impact and support a certainly significant impact on sustainability as well.
Thank you, Yasmin. Matt.
Thank you for the presentation. There was an awful lot in there. A couple of things really. The first is really trying to connect the two sides of your presentation. So you started off by talking about policy and the approach to put health impacts into decision making, and then the second half about the really exciting work on food sustainability ultimately. And I'm interested in the criteria used in the food initiatives that would test success in delivering health outcomes. Whether you at the stage where you're sort of saying, well, if we're successful with what we're doing in creating sustainability within, building connection to the farming community or building sustainability in food supply, would there be an impact that would be measurable on our population that sort of underlines then our success in having a health impact? You see what I mean? I'm kind of interested in the outcome. And then the second, a really quick thing. So the ICB, and I forget which ICB actually won it, but obtained a grant award for something called the Obesity Pathway Innovation Programme. Great, you're nodding your head, so you're connected in with it, because it talks a lot about, I've just opened the scope of it, talks a lot of what you've said. So it's really good that we're connected on that. That's confirming that. Thank you.
Please, yes, please answer.
Yeah, just to provide some assurance on that map, we are linked in through OPIP, which I know this is recorded, but I think it's embargoed till Monday. We are linked in, and Barty within the team was helped write that bid moving forwards. Help write that bid. But in terms of moving forwards, looking at outcomes, yeah, we're still quite early in that stage through the whole systems approach and the gold element. But it will be definitely something that we're looking at, and how can we put in a logic model, whatever it might be, so that we can demonstrate that success and those outcomes moving forward.
Thank you so much, Holly. Mike, would you like to say something?
Yeah, thanks all. And I was going to ask a very similar question to Yasmin, because I was thinking about obviously with the event, it said there was NHS partners, but understandably there's a lot of focus on district councils because of the planning and the housing bit. But I suppose to take your cue, Yasmin, I'm thinking in the early days of ICBs, there was a lot of talk about the role of the NHS as anchor institutions, and that's either gone quiet or I haven't heard it as much lately. So is the way forward, is that now being taken forward via the neighbourhood health programme?
In effect, yes. Yeah. And I think that's why it'd be really good to connect the dots up again and refresh that.
Very much. Can I ask actually a question of my own, actually, for Natalie and Jenna? Talking of the local plan there, is this retrospective or is it just starting now? So has there been this concept ever in the local plans? Because it feels like being a county councillor walking around the streets, there's not a lot of thought given to the well-being of people that are next to sheds and large industrial places or large housing estates. So the question is when do you think we will notice a change?
Thank you for the question. It's a new piece of work, as in, I suppose, new on how fast things can work with planning. So that started in 2021, and we've slowly, through the different consultation periods and iterations of a plan you have to have before they come to examination, we've embedded the policy within the draft plans, which a number of them go to examination this year, and there's some next year. That then will trigger the ask of developers to do the health impact assessment. So it's been lots and lots of work to put that in, and a few delays due to unmet need, housing numbers, etc., delays in plans, changes to the national planning policy framework, delays in plans. So we would have hoped we would have been a bit further ahead and maybe had some of the policies and some of the local plans adopted to see how that was working. But I think just the first one would be this summer time. So there's been, I think maybe from when I started in a bit of quick research, there was a couple of local plans that had health impact assessment ask within them. The thresholds, there's a numerical threshold usually around units or land space,
Right.
were quite high. Didn't sort of catch many went through, or we've made a really robust attempt, and hopefully it's robust, to do screenings with a health impact assessment. You would screen yourself sort of in or out of needing to do one. And I think there was some in local plans, but you could almost write maybe more of a qualitative statement as to why your development wouldn't make a health impact. Whereas now we've become strong and we put the unit numbers, and that means you will do a health impact assessment proportionate to what you're suggesting, but with those conversations will be there. Whereas prior to that, perhaps you could have made a decision on your application, and that would have been accepted, and because of our developed relationships with planners as well, I think that sort of maybe they'd seek our opinions on whether that was the right outcome as well from our work. So yeah, it's brand new really, and with the national significant infrastructure programs, which I suppose just being, if it was big employment development, it might go through that national planning route. That's nothing I've heard of before locally. That's actually been leading on that.
Sorry, I was just going to come in and say as well, I suppose in terms of progress that we've made at Leicestershire against kind of the national benchmark, we probably are slightly ahead of the game in terms of healthy placemaking. I think that's fair to say. We had feedback from the Town and Country Planning Association to say that some of the conversations we were having around strategic sites being brought forward, for example, and we're very much part of that conversation and contributing to that through health evidence and data. They did note that was very progressive, something they've not seen at a local authority level. And then in terms of the work that we're doing around the nationally significant infrastructure programs as well, those projects again probably slightly ahead of the curve in the the examiner invited us in. The inspectorate had that interest in some of the health concerns that we'd raised, so that was really positive from our point of view as well. So it's kind of early days, but we're looking forward to taking those next steps as well. Thank you.
Fantastic. Well, thank you so much. That's very positive. Is there any other questions, please? Yona.
Thanks, Chair. It really is a whole positive approach, and it's really heartwarming to hear. I just wondered from a Health Watch perspective, thinking about the healthy placemaking particularly, in terms of how you can involve or taking the philosophy that local communities should be a key part of the placemaking, because quite often they'll have a wide range of views about where they live or work, and whilst they may not have the impetus to change it individually, by bringing it together in a large quantity, that can be quite influential. And actually, to be fair, the voluntary sector and local communities are key deliverers at a really local level, and meeting or matching in with the neighbourhood models of care, we hope that will come through further development. But local communities would be very much about working as volunteers to, just think of all the litter picking that goes on as an easy example. And the other aspect of community involvement would be around local schools. Particularly primary schools are really key. Sustainability, food stuff is a key element for that age, and building it on as they go through into secondary care, and seeing that given some emphasis, I think it is really good, and hopefully will give us what we are looking for in terms of the impact that Matt mentioned coming down the road later.
Of course, go for it.
Thank you. I was just going to pick up on some of the community engagement so far, especially in terms of the healthy placemaking work. So as part of those strategic health impact assessments that we've been applying to the local plans themselves, that was very much done in collaboration with lots of different people feeding in, including that community voice as well. So not only, like Jenna said, it was important for us to be able to look at what their health priorities and the health challenges were in that particular area. We really needed the on the ground kind of insights actually to see what matters to people, and that came across really clearly with some of the local plan work that we did, where actually we kind of thought our health challenges would kind of sit in these sorts of arenas, and actually what came through really strong and loud was actually a lot of the concerns were around local parks and antisocial behaviour and perception of safety in local parks. So again, that's something that then we could bring that the richness of that information then into when we were working with the planners with that district to make some of those recommendations, because they already had some really good policies in terms of access to green and blue space. But it was, how can we take into account those feelings and perceptions around safety, to make more robust health and wellbeing recommendations really. So again, starting point, but we know now how beneficial obviously including that voice is, because it really just widen the scope of what we're looking at. So that's something we're definitely building on more and more in the future, as well as we carry on with this work. Thank you.
Thank you so much. Is there any other questions before we go to A motion? Nope. Good. You're all happy. Thank you so much. Okay, the proposed motion is that the board notes the progress made in relation to delivering against the staying healthy, safe and well priority, and B, notes the progress being made in relation to delivering against the cross-cutting priorities. Are we all agreed? Yeah, all agreed. Fantastic. Okay, any against? Got to ask. Thank you so much. That's really good. Thank you. Welcome, Joe. Okay. Okay, on to our next report. This is number 7. So this report provides an update of the Active Together Partnership Physical Activity Framework 2022 to 2031, and Active Together's approach to reviewing and refreshing the framework. This report will be introduced by Jo Newbury, Active Partnership Director. Thank you so much.
Thank you, Chair, and good afternoon all. My name is Jo and I've recently taken over as the Director of Active Together, and I'm really pleased to be here this afternoon to give you some information on our Active Together Partnership Physical Activity Framework and the approach that we'll be undertaking to refresh and review the framework to ensure that it's really still fit for purpose. Can I have the next slide, please, Abby? Thank you. So I did just want to start off by briefly explaining some context to who Active Together are. We are the local partnership for Leicester, Leicestershire and Rutland, and we are one of 42 similar organisations nationally. An Active Partnership is here to support organisations and individuals to help people to move more. The Active Together core team is actually hosted by Leicestershire County Council. We do have an independent board that really provides and sets our strategic direction of our local communities. The Active Together Partnership is the collective name that's given to the core team and our stakeholders and our partners. And it's really because we have that shared ambition of us supporting our communities to move more. The partnership approach is really important when I talk about the physical activity framework. And it is really important to note that I'm talking about a framework that has been developed with and for our partnership and not just for our core team. But before I talk more about the framework, I really just want to provide some context into why physical activity is important and perhaps the challenge of physical inactivity that we have in Leicestershire. So, physical activity is often thought as a nice to have, and actually it is essential in supporting people to live happier and healthier lives. Physical activity can have a positive outcome on health and well-being, and the Chief Medical Officer really did give a powerful quote talking about the benefits of physical activity, stating if it was a drug, it would be referred to as the miracle cure due to the impact that it has on prevention and treatment of a number of illnesses. Physical inactivity does contribute to 1 in 6 deaths, and conversely, being active can support up to a 50% reduction in the prevention of numerous long-term conditions. But it's not just health and well-being benefits. Physical activity can also contribute to wider outcomes such as economic growth, skills, employment, planning and climate change, just to name a few. But despite can we have the next slide, please, Abby? Thank you. But despite the well-published benefits of physical activity, we do still need to do more. The latest Sport England Active Lives data tell us that 34% of Leicestershire's adult population do not meet the Chief Medical Officer's guidelines. So that's to do 150 minutes of physical activity a week. But actually 23.1% of those are classed as inactive. So that means they do less than 30 minutes of physical activity a week. And we have a similar trend for children and young people. The survey outlines that 49.8% don't meet the recommendations. So for children, that's 60 minutes of physical activity a day. And of that, 28% are classed as inactive. So that means they do less than an average of 30 minutes of physical activity a day. And equally, it's important to state that there are some disparities in the data. We know there's inequalities in physical activity levels within our communities. And we really need to work to tackle physical inactivity. We know the greatest health benefits are gained from supporting people who do absolutely nothing to get them to do something. And we really need to try and reduce the inequality in access to physical activity. Next slide, please. But it's really fair to say that reducing levels of inactivity is a complex challenge, and it's the collective power of collaboration across multiple partners that will enable a difference to be made. And I think it's really important to note that getting people to move more is not just a responsibility of the physical activity sector. The need for a collective approach is supported through the development of the Active Partnership Physical Activity Framework. And this outlines the long-term priorities to tackling inactivity levels through working in collaboration with our local communities and, importantly, a wide range of partners. So the framework itself, it was developed through consultation with a range of partners and residents, and it also aligns to national and local physical activity and health and wellbeing strategies. Importantly, the physical activity framework was developed as a partnership framework and not just the Active Together core team document. It's only through collaboration that the priorities within this document will be delivered. So the framework itself sets out a shared vision and coordinated approach to physical activity levels across Leicestershire, Leicester and Rutland. And I won't read them all, but the statements in the blue boxes really do outline the aim of this framework. Next slide, please. So working through the key themes of people, place and partnership, the framework identifies 10 key priorities. So that's what we will do. These support the collective vision of where we want to go and identified outcomes, so the difference we want to make. Locally, partners endorsed the physical activity framework back in 2022, and they've joined the Active Together core team to think differently and work collaboratively in both policy and practice to deliver the strategic priorities and support the vision of Leicestershire, Leicester and Rutland, a place where physical activity is part of daily life, leading to people living healthier and happy lives. Thank you, Abby. And I'm sitting here today to say the framework is now at a midpoint in its delivery period, and it is providing us a really good opportunity to review progress and make sure that it remains both relevant and impactful. The duration of the physical activity framework is longer than any other framework that have been in place previously. It was recognised to achieve the vision. The partnership needed time to embed system change, but also to change our local residents' behaviour and have an impact on the inequality measures. However, the framework is at that midpoint and it does provide an opportunity to review its progress. Whilst we recognise that the time frame is still applicable, we know there's been significant changes in the landscape since we wrote the framework. For example, the physical activities sector has changed post-pandemic, and there's also been significant changes to both national and local priorities, as well as funding levels and capacity levels. We are anticipating further changes from national and local partners from April 2027 onwards. So our Active Together board has therefore agreed that the Active Together core team will undertake a review of the physical activity framework to ensure our priorities are still relevant to our partners, our funders and our residents. It is, however, important to note that it will be a refresh of the framework and not a rewrite due to the initial commitment of that longer term framework. As part of our process to refresh the physical activity framework, there is a need for us to reconsult with both our partners and our residents. So partners will be engaged in a planned refresh to understand how they've utilised the current document, if the priorities remain relevant, and to further explore how the framework can be endorsed and adopted by a wide range of stakeholders. Key funders of the Active Together partnership will also be engaged to ensure there's further alignment with the national and local strategies. Let me just go back one slide, Abby. Sorry, no, you're okay, thank you. And then in terms of consulting with our residents, we currently have a physical activity and wellbeing resident survey that's running until the 10th of July. The survey will help us produce a picture of our residents' current levels of physical activity, the challenges they face to be active and their future intentions. This in turn will help us as a partnership shape the offer for our least active residents. And it's intended that the consultation on the physical activity framework will be undertaken in 26 and our refreshed framework will be in place by April 2027 and will be in place for the remainder of the initial time frame right up to 2031. Next slide, please, Abby. Thank you. So I think having the opportunity to share this information today with the Health and Wellbeing Board on Physical Activity Framework is essential to ensure that physical activity is embedded into system-wide approaches to prevention, reducing inequalities and supporting healthier communities. I said right at the beginning, but I will repeat that physical activity shouldn't be seen as a nice to. It has the power to change the lives of our communities. However, it is the collective power of collaboration that will enable us to make that difference. The refresh of the physical activity framework presents an opportunity for the Health and Wellbeing Board to demonstrate the collective leadership in using physical activity to improve health and wellbeing outcomes. And I would really ask members of the board that they note the support to reviewing and refreshing our physical activity framework, support the collective approach to our framework, and importantly, champion physical activity within their respective organisations and partnerships. Slide, please, Abby. And finally, I would just like to end by saying thank you for your time today. If you would like any further information, there were some links included in the report, but I've included them back on the slides today. But thank you very much.
Thank you very much, Joe. Open the floor. Any questions? Kevin.
Hi, Joe. It's just an offer just to say that, yes, great. You know, I think you have full support from around the board here today about getting involved and helping you with the refresh. Just to say that we'll be happy to put anything through our newsletters that go out through to the voluntary sector and other individuals. Also, I have a captive audience now of 70 chief execs that come together for the Chief Execs Network. So if you want to use that as a vehicle, more than happy for you to come along to one of those as well.
Thank you, Kevin. I would really like to take you up on that opportunity, and I can be in touch outside the meeting of how we do that moving forward. Thank you.
Mike, would you like to say that?
Yeah, thanks, Joe, and thanks, Joe. I mean, the other bit, Joe, I'm thinking is, refresh rather than a rewrite. Yes, I would support that, not least of which because I'm thinking Active Together were ahead of Sport England in embracing that kind of all system, word of the day, approach to physical activity rather than the kind of sport-based one. So having probably trumped Sport England a little bit into embracing that way of working, I don't really see the need to go back to a different way of doing it.
Happy to respond to that, Mike. I agree. We are anticipating, so Sport England will be refreshing their priorities. We should know what they are in the summer for our next 5-year of system partner funding, but they do align to the approach that we've taken locally. So as far as I'm aware, there's no priorities within our framework that we won't align to the Sport England framework.
Thank you, Joe. Is there anybody else? Yes. No? Okay, I've got one for myself actually. I was reading somewhere, and perhaps you can corroborate it for me, that 20,000 users across are using Active Together services each quarter. Is that right?
If we look at our whole partnership, there's probably more users than that. We do have a substantial. We work in partnership with our local authorities, sport and colleagues. We work in partnership with our clubs, our organisations. That figure is probably the figure of the number of people accessing our website as well. So we do have some really good figures. Our impact report will be out in the next few weeks. So I'm more than happy to share a link to that to the board, and you can see some of the impact that we've had on our local communities.
It's brilliant. Thank you, Joe. I think we're all looking forward to that. Okay, I'm just going to go on to a proposed motion then. That the board notes the approach to reviewing and refreshing the physical activity framework, supports the physical activity framework and the collaborative systems approach to delivery of its priorities. C, champions physical activity within prospective organisations and partnerships, thus supporting a coordinated place-based and preventative approach which uses physical activity to support residents' well-being. And D, promote and encourage engagement with the physical activity and well-being residents survey. So are we all agreed? Thank you so much. It's passed. Thank you.
Thank you all.
Thank you so much.
Tracy.
Hello, welcome to Lisa and Tracy. Thank you very much. This is item 8, the Better Care Fund 2025 to 26 year-end update. This report relates to the year-end performance reporting of the Better Care Fund, BCF, now I know, programme for 2025 to 26. This report will be presented by Lisa Carter, Health and Social Care Integration Services Manager, Leicestershire County Council. Thank you very much.
Thank you, Chair. Okay, so I'll go through the year-end report for 25-26 first. As you've mentioned, this is pretty standard and follows basically the format of the quarterly returns that we've had to do throughout the year. With regards to times for timetable for decision making, the Chief Executive approved the return by her use of delegated powers for the Health and Wellbeing Board, and this was done on the 28th of May, and it was submitted in time for 5th of June, hence why it's a retrospective report to the board. Just a couple of things to pick out from the background. This was published on the 12th of March, and it came with a set of requirements and a template for the year end with a submission deadline of 5th of June, as I mentioned. So it consists of tabs on the Excel spreadsheet about the four national conditions and whether these have been met, confidence assessment on achieving the metrics as they are against the targets that were set at the beginning of the financial year, confirm the level of income received and any year-end feedback. In terms of income, we received all of the income and we have currently spent 98% of that. The difference is within the Disabled Facilities Grant, the DFG portion, which is slightly short. It usually is, that's not unusual, because Disabled Facilities Grants get approved and then because of works, etc., it has a bit of a lag for them to be completed and for the funds to go through. So there's always a little bit amount of funding that is spent in the subsequent financial year associated with that. So as at our current levels, we've committed to spend all of the money, but as in just spent is 98% of the overall fund, which was 84.8 million, as you can see in the income box in paragraph 12. Just a couple of bits of information there regarding the changes to the funding for 25-26. So the discharge grant became part of the Better Care grant along with the IBCF, which is the portion allocated to adult social care. Paragraph 14 tells you the uplifts for 25-26 and then paragraph 15 tells you what the overall expectations are around those allocations. From paragraph 16 onwards, it goes into the metrics and where we are currently against those with actuals. I have to say that with all of the metrics, there is a lag for the final quarter of data, so they don't necessarily fully align to whether we're on target or not. So we do some in-year preparatory work to try and figure out whether we're currently on target. For emergency admissions, we are definitely on track to meet that target. Discharge delays, we're not currently on target. Discharge delays is split into a couple of indicators. One is about the average length of discharge delay for all acute adult patients in terms of days, and then the other half is around the all discharges and the length of time that they take as well, and the percentage of people that are going out on the day that they're supposed to be discharged.
residential admissions to care homes for people aged 65 and over. We're currently on target in terms of actuals, but we have done some in-year modelling based on a newer method. I won't go into the details mainly because I'm not too sure on it myself, but there is a new method of measurement of that, and it does look like we might, by the time the data catches up with the year end, we might have slightly missed that target. However, we are looking at more detailed analysis to try and get a better understanding for some of those reasons. An update on the national conditions. They've all been met for 25-26 plan, and from paragraph 18 onwards you can see the 4 national conditions as they were for 25-26 planning considerations. They have slightly changed, but I'll go on to that for 26-27. And that's it for the year end.
Thank you very much. Any questions or comments, anybody? No, it sounds like you've achieved the objective, which is what it's all about. So thank you very much. So I'm going to propose a motion then, which is that the performance against the Better Care Fund BCF outcome metrics and the positive progress made in transforming health and care pathways in 2025-26 be noted. The board notes that the year-end BCF 25-26 template attached to the appendix to the report has been approved and was submitted to the NHS England for the 5th of June 2026. Submission deadline, this was completed under the delegated powers of the Chief Executive, as the submission date was prior to the HWBB meeting 15th of June 2026. Okay, all agreed? Thank you, sir. You like putting your hand up, don't you? Thank you so much. So we're going to go on to number 9 now, which is our report for the Better Care Fund for 2026-27. So I'll believe that is that you again, Lisa?
It certainly is.
Okay, thank you very much.
Okay, thank you. So this is the new one for this year. We had an integration exec that saw the draft submission as it was, because yet again we've had to do the delegated powers from the chief exec of Leicestershire County Council to meet the submission deadline of the 19th of May. So just a bit about the integration exec. It considered the draft BCF plan at its meeting on the 5th of May, and the executive supported the contents of that as it was at the time, which it wasn't fully complete, but it was a draft to as near as complete as we could get it at that point. The documentation was published on the 18th of February with a submission date of the 19th of May, and obviously that didn't match with today's meeting of the Health and Wellbeing Board. So yet again, it's a retrospective report. There is a refresh of all of the paperwork in the background to this year's plan, which includes some information on the things that were required in it, and these can be found in links that are at the bottom of the report. For a full year's plan, not only do we have the numerical template, but we also have a full narrative of explanation, both of which are attached as appendices A and B to this report. And the planning principles document, which is published by NHS England, is attached to as Appendix C to this report, so you can see some of the things that are required. This year, for 26-27, there are only 3 national conditions. These are outlined from paragraph 18. One is effectively support the delivery of integrated and preventative care. 2 is to comply with the expenditure and grant conditions. And 3 is effective governance reporting and engagement. In terms of the strategic narrative, this has been set out in Appendix B and has been a piece of work that we started back in end of January with Health and Wellbeing Board members and members of the Integration Exec and its delivery group. And what we looked at was what we'd achieved within 25-26, how we think we needed to improve to meet the kind of national framework and guidance for 26-27. And we had a workshop to discuss the kind of priorities that we wanted to include in this year's plan. And they included further integration in terms of looking at how we work with our
voluntary sector, how we look at delivery against the new neighbourhood priorities that are being published, of which the BCF should be a conduit for delivery of those things. All of that totals the income, because each one of those lines has got a value of spend against it. And for this year, it's an overall envelope of 86.5 million, just over. 5.7 million of that is for disabled facilities grants, which is was slightly uplifted in January of this year. And the rest is split into the local authorities better care grant and then the contribution from the ICB. And they have a minimum contribution to make for services that integrate health and social care. The metrics have slightly changed as well. The three initial ones that were in 25-26 are remaining in this plan. But as well as that, we have got a proportion of people aged 65 and over discharged from hospital with reablement and that are still at home in the community 12 weeks after that discharge. It's a very similar metric to what we've seen in previous years, but the measurement of which is slightly different from that. So it's not actually comparable. So you'll notice if you've read the narrative, you'll notice that there's quite a wordy way of saying that there's two sets of data aren't necessarily comparable from when we used to measure it 2 years ago to the measurement that we've got at the moment. So essentially for that particular metric, we've set a target that is in line with the national average to make it sort of quite a sensible decision. In terms of the other three metrics, just thinking about what we've gone through in 25-26, our targets have been based on the actuals as we had them for 25-26. So in terms of the emergency admissions to hospital, we're looking at a 2% reduction on what we think our actuals are going to be. For discharge delays, we know that we've not met the 89% people in 25-26 that we wanted to go out on the day that they were supposed to. So we've actually reduced that to 87.7% because we just know that we're not in a position to meet the target as it was. So we've actually reduced the target. And we have set for those people that do go out or that don't go out on the day that they're supposed to be discharged, we have an average length of discharge for those people of 3.9 days. We have been challenged by NHS England on that because they think it's too difficult to meet. But what we have said is that we have some quite stringent plans with partners in place to try and meet that 3.9 days where we can, which we've all put into the narrative. In terms of residential admissions, again, it's quite difficult to compare the measurements because they measure them differently. So what's in the actual numerical template is slightly different to what you'll see on cover reports, etc. But on average, we're looking at 858 admissions per month, which is as it was on the 25-26 report, which it's actually measured as a rate per 100,000 population, which translates to 552 per quarter, I think it's measured as within that spreadsheet. So it's quite difficult to explain in terms of comparative data, but we've based it as far as we could on the actuals that we've got so far. I have actually had to make a slight amendment to the emergency admissions metric. In the original narrative that was that was sent to NHS England, we had based our template on the proposed plan for 25-26 instead of on the actuals. So that has been amended and it has been resubmitted, and I'm happy to send that to you and for the board to have a look at the changes that's meant in terms of numerical figures. So it has just brought our narrative in line with the template, which it wasn't before. Moving on to the next section of the report, which is about the
ambitions and how we interpret reflecting some of the underlying changes for demand in the coming years. So previously we've had to do a demand and capacity return. That hasn't actually been required this year, but we have still included it as part of the narrative, because even though there's not an official template, a numerical template for us to fill in, we have still had to look at the increases in demand and making sure that our capacity covers that across health and social care services. So if you have a read through the narrative and you're interested, there is actually a section and a table in there that shows what we think that's going to look like in 26, 27. That's it.
Thank you very much, Lisa. Is there any questions or comments? Sorry, I can't see your name. Hello, G. Sorry, don't worry.
Can I just check, Lisa? And I'm probably not on the ball with this one, but I didn't really see anything around mental health in the narrative. Obviously, there is some funding or some spend on mental health. So I'm just wondering why we're not sort of reflecting massive delays we've got in mental health discharges as well.
Yeah, we haven't done anything specifically around mental health discharges, particularly, but we can certainly look at that. Even though we've done our submission, we can look at some of the things that we might want to do. It's worth saying that this is just a 1-year plan. So if we want to look at some improvements on mental health discharges, then we can certainly pick that up. We have retained the amount of funding that we put in last year. So in 25-26, Jean, you actually asked me exactly the same question about mental health funding. And we did at that point for last year put some funding in to support mental health and mental health discharges. If we've not seen the results that we wanted to see from that additional funding, then we perhaps need to look at some of the reasons for that and whether actually we need to do something different or perhaps bolster that, or perhaps think of a different way of funding it, etc. So happy to have a look at that in year, ready for next year.
I think that'd be really helpful, Lisa, because we are seeing still actually now steadily increasing number of delayed discharges, particularly for older adults as well as adults in acute mental health. And maybe it'd be really helpful if we could have perhaps a little bit of a very small, very snappy working group, just having a look at that so we can perhaps build that into the following year.
Absolutely happy to, yeah.
So much. Okay, Yasmin.
Thank you, Chair. Just on the back of that, in terms of wider discharge, and seeing that obviously we've put quite a ambitious plan metric in there from a Leicestershire perspective. I guess it's just tying it back in with the sort of strategic discharge group as well, in terms of making sure that that our plans reflect that as well, because the last thing we want is we've put something in but we've not necessarily reflected that in the sort of working strategic plans as a partnership.
Yes, so I'm relying heavily on that strategic discharge group to meet that target. So what we've been doing is looking at the things that we can do with that group, and most of the changes we think we could possibly make to meet that target around the SOPs, so the processes. So if we can work together as a group to try and minimise the amount of delays that are there for discharges, then I think we could probably get to that target. It is a target that we have put across sort of LLR. We're not kind of unusual in Leicestershire, and we do want to make sure that we don't kind of fall back on the table, because we are actually in a really, despite the fact that it's still too long, the average requirement across nationally is 3 days and we're at 3.9, but we are much better than the England average and the national average and the East Midlands average, and we want to kind of stay there. So that's why we're trying to work really hard with that group to do something around the processes, because that's the only way collectively is how we will shave off where we are at the moment, which is 4.4 days down to that 3.9. So we want to reduce it by a further half a day.
Sorry, just to pick up on Yasmin, that whole thing about looking at the standard operating procedures is perhaps something that we need to do a refresh on, just because we have changes in personnel across health and social care, and it's just about ensuring that what's written is being adhered to, or if it needs changing, we make those changes to facilitate the. Okay.
very much. Any more questions? Thanks. Okay, thank you very much, everyone. Oh, sorry, Matt, missed you.
Thank you. There's an aspect of the Better Care Fund. There's a policy aspect of the Better Care Fund that I've worked in a couple of different integrated care boards, and I've been told by my director of adult social care or their equivalent, there's a review of Better Care Fund objectives, outcomes, or metrics that will be measured on, and it always seems to be pushed further and further back. But we're told, John's laughing, he knows what I mean. It feels like there might actually be something coming up. I might be out of date now. But at that point, and if it does happen in the next year or two, I think we need to be ready to have a bit of a root and branch review of what's in the Better Care Fund, because the policy direction is really clear. It's about discharging people. It's about stopping people coming into our acute emergency system, about getting them out really quickly and discharging them safely with what they need to prevent a readmission. And they're core deliverables that aren't going to change over time. But I think if we looked at what we put under the Better Care Fund heading, I think there'll be parts of spend that either don't quite do that or sort of slightly tangential to it, or indeed could actually be done differently and more effectively. And at that stage, being able to review it with a purpose, with an eye on the future, would be quite a useful sort of objective. And maybe we don't wait for a change in the policy direction or the enablers, but it's something perhaps that we should consider. Thank you.
Thank you, Matt.
Can I?
Sorry, go in, Lisa.
I disagree. I think there's a massive percentage of our BCF that is focused on community delivery. And the reason it's focused on community delivery is because we essentially don't want that acute spend, and we don't want that acute demand, because that's not right for everybody. I think the thing that you've also missed there is that we do have a concentrate not just on the NHS, but on reducing adult social care demand and or reducing people needing residential care and being supported to stay at home. And that is both really from an NHS and an adult social care perspective, and because it's better for the person. So actually I think that we've got a really strong BCF, and every year we do exactly the same process. We go through it and do a root and branch review. And we did that at the end of January, and it was to look at making sure that we met the requirements of this year's Better Care Fund. Absolutely agree that when those priorities change, we should look at it again. But I do disagree that we haven't got that right as at yet, because I think we've done it year on year, and we've been really clear about making sure that we've got our focus on community, home first delivery. And I'd say that that's probably reflected if you look at the percentage of spend and where that sits. I think that's currently in the right place. Whether it's delivering the right metrics at the moment, perhaps not. So I think there's some work to do there. But I wholeheartedly agree we will do a root and branch review, but that would be nothing different to what we do every year.
Yes, of course.
Well, thank you for giving me the assurance. So I'm coming at this from a couple of different angles. What is the report says that the last year's report says we hadn't achieved certain things. So in my mind, the question is, well, does that indicate that we're not putting enough resources into Better Care Fund because these things are set and we set the plans, and presumably we set plans we believe are achievable? And if they're not achieved, that raises the question either we misjudged how much we needed to put into it, or alternatively, we put in things that were less effective than they thought they'd be in delivering the outcome that we've set ourselves at the start of the process. So that's one angle. The other is that I was in post when the Better Care Fund first came in as a CCG Chief Finance Officer. And I was working in a completely different part of England at the time, but I know that we constructed it on the basis of what felt like resources that we could point in. And a lot of them were actually core program resources, particularly within, you mentioned community. I mean, I agree, absolutely. There were community-based services, but they weren't necessarily, it wasn't necessarily completely clear at the time that they would be pointed into delivery of the policy objective. And they're kind of built around delivering things that you suggest would deliver the policy objective, but they weren't created and put in place specifically to deliver the policy objective. I think that now it could have been done differently here in Leicestershire County, but that's just my experience. I saw something similar in Lancashire, which I referred to when it was first constructed, and in Lincolnshire, where I've also worked. And I think we failed to perhaps, and I'm not disrespecting or attacking the process you've done. I'm sure it's a really thorough job, but I suppose I'm coming at this from a perspective of having known before that we sometimes defer or delay these sorts of reviews of effectiveness, because of the potential change coming down the line. I think let's not wait for that to happen before we assure ourselves that it's been done in the best way possible. And I could be, John's going to correct me now, I could be talking well out of line on this, but that's just a perception I have. And this isn't just about what's put in by a local authority. I'm talking about it from an NHS perspective as well. Thank you.
Do you want to come back on that, John?
Yeah, if I could. I don't want to come back on that necessarily. I want to probably try and agree with both Lisa and with Matt, if that's possible. So there's a couple of things. One is there's a kind of a principle and a practical application issue here. And it probably goes back to the fact that the Better Care Fund is now getting up to 12 years old. It was started in 2015, and it was built on the back of really 3 burning platforms. So the first one was around discharge, and at that time, and if you think we've got problems now, well, we could go back to 2015, and it was as significant then, if not more so, than it is now. The second was that social care at that point financially was in crisis. And the third was the introduction of the Care Act. So on the back of those 3 things, 3 pots of money were brought together, or 4 pots, including the Disabled Facilities Grant, which was at that point a social care capital grant, I hasten to add, but anyway, never mind. So those pots of money were brought together to try to resolve those 3 things. We are now 12 years on, and whilst we still have pressures in discharge and what have you, I'm sure that, I can't get away with not saying that social care doesn't have a financial pressure, because clearly it does. But the world has moved on quite a lot. So I think there is a principal thing of saying, actually, when Matt commenced this conversation, he talked about the review of the Better Care Fund, which has been put off and put off and put off. And we were expecting it to be more radical, I think, this year than it has been. I think that's fair to say, built on the back of the 10-year plan and the neighbourhood work, which we thought would be more significantly kind of expressed through the Better Care Fund. Practical issue is that all the money is committed. So if we want to free up funds from the Better Care Fund, we have to stop doing something. And that's really difficult when you've committed it, and when you're committed to either contracts commercially or where you're committed to staffing. It's not something that you can swiftly change around. Lita is absolutely right. We do go through a process every single year where we review each element of it, and particularly in the last couple of years, we've done that in more detail than we have for a number of years. And we may need to do that again more strategically in terms of the overall pot, and it might be actually that we need to put more money in collectively rather than trying to just work with the confines of what we've got. Because I think there is an opportunity to do things differently and to use the funds differently. But equally, what we can't do is take money from current provision that is supporting people to be independent in their own homes, or to have services that they currently rely on. So it's a really tricky nugget, I think. But maybe there's an opportunity to do something that's a bit more kind of creative, not just confined within the funding that we currently have. That's what I would say.
Thank you, John. Also, mind that really we need to do a bit more talking on this. I think is that something we can organise,
We can. I'd probably wait until the neighbourhood policy framework that comes out. I think it's due in July, because I think a lot of that will link to kind of what we've got within the BCF at the moment. But John's absolutely right. We are currently fully committed to each of those lines within the BCF, and each year we don't have additional funds put in, certainly not from the last 2 years. Previous to that, we did uplift it slightly. So I do think we need to be really careful about what it is that we want to aim to do. And I don't think there's anything wrong with moving things out and putting new things in. That's absolutely agreed. But you can't go below your minimum spend and your minimum contribution. So you can't take it all out and put 50 quid back in. You've got to be within the confines of what is nationally expected spend through your BCF or more. So if the ICB would like to commit to future enhancements in funding, then that would be great. But so far this year, we've not been able to do that. But I anticipate in future years, we can certainly do that. And I would say that within the next 3 or 4 months, we can certainly look at doing a bit more of a workshop on the kinds of things that we might want to see within the BCF and think about the art of the possible. It's not beyond the realms of possibility, but I will say that if we do that, we can't commit to absolutely doing it until we've got the policy framework come out, which will be next January, February time, which will again dictate to us. So we might think we know what we want to do with it and the changes that we might want to make, but as Matt's pointed out, often the policy framework doesn't do what it's meant to do or says it's going to do in the following 12 months. So yeah, absolutely happy to do that as long as people realise that we can only go so far, but to get your ideas would be beneficial.
Thank you so much, Lisa. Okay, we've got a proposed motion. I'm going to just add an extra line in there, which isn't there, which is basically, can we talk about this in the next September? Our next meeting, I believe, is in September. If we could have a catch up on that. Would that be okay with everyone? Okay, so the actual proposed motion here then is, let's get it right. The board notes the content of the report, notes the Better Care Fund Plan 26-27 numerical template attached as Appendix A and the narrative document attached as Appendix B that details the contents of the BCF plan return, notes the action taken by the Chief Executive of Leicestershire County Council to use powers of delegation to approve the BCF plan for submission prior to the deadline of 19th of May 2026. Are we all agreed? Okay. Thank you so much. That's really good. Okay. Welcome, Kevin.
Thank you, Chair. This is a bit of a weird thing, isn't it? Because I'm usually sat over there listening to everyone else, and now I'm here talking to you guys. So yeah, this could be a bit of an interesting experiment. Let's see how it goes.
Let me just introduce you to it. So our next report is on the voluntary action Leicestershire offer. This report provides an overview of the work undertaken by Voluntary Action Leicestershire in supporting NHS colleagues, commissioners, local authorities and wider public sector partners. So Mr. Kevin Allen Kimani, Chief Executive of VAL, will present the report.
Thank you, Chair. So obviously there's a detailed report that you've had in the pack. I'm not going to go through that verbatim, you'll be pleased to hear, and I'm not going to go through everything with you, but I want to pull out some key highlights for you, just to give you a bit of a flavour about what we are doing at VAL with regards to how we support, work in partnership with all of you really in various different guises to ensure that the voluntary sector and their service users, clients, lived experience can be fed into plans, strategies and other things like that. For those who don't know, Voluntary Action Leicestershire, we've been going since 1965. So we had our 60th birthday last year. That's Val's birthday, not mine. Had quite a few people saying it was my 60th. Nope. But with that, we've been doing the core work around supporting the voluntary sector and volunteering because we are a nationally accredited volunteer centre. We've been doing that since we started up in 1965. We do that, next slide please, Abby. We do that through a dedicated team called our sector support team. And as it says, they're providing training, resources, support for the voluntary community and social enterprises across Leicester and Leicestershire. But the figures and everything I'll be talking to you about this afternoon are purely Leicestershire. So don't worry, nothing's been mixed in from the city. It gives you a flavour about what we've been doing in the county. And it is a very small team. So we do a lot on only the equivalent of 4.85 FTE and a range of different positions within the team. But we do have a great reach, and I'm sort of very proud of the work that the team do. I started off myself at VAL 24 years ago this year, actually, in that team, and basically to see it still going and what the impact we can have is really great. Next slide, please, Abby. So just to give you a bit of a flavour of some of the key stats and figures for you. From 25, this is the 2025-26 financial year, we supported groups to raise over £710,000. What we don't do is we do not write funding applications for people. We actually support organisations to empower them, gain the skills, gain the expertise so they can actually bid, hopefully by themselves in the future, but we all work with them. We also last financial year, supported 791 groups across Leicestershire in a range of different things, whether that's through coming to events, accessing our training. Out of that 791 groups, 212 of those had what we class as intensive one-to-one support. And that's basically the need or the issue that they presented with needed more than just to come on that training, come to this event, meet some other like-minded people. We actually needed to have a caseworker to go through with them to actually, see what we could do with that. We have a monthly newsletter, goes out to over 3,500 individuals, and that's not just the voluntary sector. That's made up from some of you sat around this table today, and also made up from other partners and members of the local community themselves. We run a helpline, so basically if people have got any, where do I start? I don't know really. Do I come to you? Is it needing to be given to an advisor or whatever? We run a helpline, which is online and also via the telephone. So last year we dealt with 485 inquiries there. As it says there, we run a range of different events and training where we had 429 individuals from county groups attend over the year. Next slide, please, Abby. As we also said, we are an accredited volunteer centre nationally, so that's something we have to go through every 2 years. We're due for re-accreditation in November this year. But as it says there, we had over 3,000 individuals, and these are unique individuals. It's not made up of someone coming back more than once. Over 3,000 individuals came to us wanting to inquire about volunteering, how do I get started, and finding an opportunity. We have supported what we call VIOs, which are volunteering involving organisations, so 354 of those, to register to our website where they can post and upload all their volunteering opportunities with our support. And out of that, we've had over 2,000 volunteering opportunities available last financial year. We do seem to know what we're doing, and I say that because 33% of individuals that inquire with us about volunteering actually convert to taking up a volunteering opportunity and taking on that role. And just to put that into perspective, nationally, the average conversion rate is 15%, and we're at 33. So we do get good feedback. We also do go back to volunteers on a regular timescale to ask them, what made you want to volunteer? How have you found it? Why have you maybe chosen that particular opportunity? So again, we're always learning and can make sure that we are re-evaluating the service that's being provided to those volunteers. And as we say, 94% of those volunteers that we've surveyed over the year have said they were very happy with their roles. 6% that aren't. Basically, what we have done with each of those is that we have sat down with them and gone into a bit more detail about why. Sometimes it's been a mismatch. They saw an opportunity, thought, great, this is what I want to do. They've started volunteering and thought, this is not for me, or I don't like the organisation, or it's not giving me what I thought it was going to do as a volunteer. So what we would do is they refer themselves back. We've been able to pick that up with them and go into a bit more detail to find the right opportunity. So that's a bit about the team and what they've been doing. On top of that, outside of the contract and a bit of added value, we attend a range of different partnerships and meetings. And next slide, please, Abby. Already. These are ones that I have been attending, and they all have or have had elements of health and wellbeing within them. So there's a lot in a range of different meetings, some led by the County Council, some led by colleagues in health, others led by district and borough colleagues. So there's a lot going on there that we are getting involved in. And some of them you may sit there and go, that's a bit tenuous, isn't it? Leicester and Leicestershire Business and Skills Board. I sit on there as the voluntary sector representative, but that board is now hearing a lot about health and wellbeing programs like Work Well, and trying to get more people back into employment again through ill health and so forth. And again, as with all of these meetings, I'm able to sit there and give the viewpoint of the voluntary sector. I'm also able to bring forward information and sort of case studies from the sector to actually put forward as well to explain what's going on and to give that lived experience. And I suppose for some of you around the table today, you'll know that I'm not shy and banging on about what about the voluntary sector and where are we within this mix and how can we support and how can we help, because we have got a huge range of voluntary community and social enterprise is across Leicestershire who are there, able to help, able to support. The other thing we've also been able to do through some of these partnerships and meetings is to broker ways in which we can bring the sector together for you. So, for example, you heard earlier from Jenna and from Nat about the healthy placemaking. Some of the work we've done with them is to say to them, okay, so what kinds of organisations are you wanting to hear from? And from our database, we've been able to actually target some groups to say either we can bring them together as a focus group for you, or we can actually, on your behalf, email out to these organisations and ask them to get involved in what you're trying to find out in that local community. And we do that quite well. So we are able to convene as well as sort of communicate information back and forth. Next slide, please, Abby. Some of the key areas that we are currently involved in around health, surprise, surprise, neighbourhood working. It seems to be the big thing that everyone's going on at the moment, and it seems to be very much something that's changing on a daily basis. We've also worked very heavily with Abby around the health and wellbeing strategy and the refresh that took place over the previous year. Myself and one of my senior managers, we sat on, I think it was 6 task and finish groups that you had, just to make sure again that we were able to feed in what we knew, our data, our collective information. But as I said there, the main big thing seems to be around the neighbourhoods at the moment. And there is a lot of, I suppose, for the sector uncertainty, as there is for colleagues around this room, about what does that look like. But we want to make sure that we are involved and we're able to start having some of those discussions, because the recent neighbourhood health framework from the Department of Health and Social Care and NHS England that was launched on the 17th of March clearly advocates and strongly says that the voluntary sector needs to be an integral partner within the delivery of neighbourhood working. And that's obviously what we're trying to do through VOW, is to make sure that we're able to ensure that the voluntary sector can be at the heart of those discussions, and also, where can, be involved in either collaboration or co-production of things that may need to take place in local neighbourhoods. Next slide, please, Abby. So how do we get to the voluntary sector voice? You might be thinking, well, if you're not, I'm going to tell you. We do it through a range of different things. So as I said earlier, we have a newsletter that goes out to over 3,500 individuals. And we also use that for our public sector partners to advertise things. So we will put in there things like potential surveys, or we need to hear about what you think about X. We'll also, if there are conferences or sessions being taken place where it's an open invite for the voluntary sector, we also will advertise those for you in there to try and get a more representative amount of different individual voices from the sector to be at those sessions. We also run a range of network and forums, and so do that. Basically, we can bring people together on a regular basis through either talking to volunteering, involving organisations together. We also bring people together around specific health areas. We bring people together around various different topics on a regular basis. Some of it just so they can peer support with each other. How are they finding it? What support may they need from VOW? But also sometimes we will bring public sector colleagues in to have a discussion with those groups to try and explain what they're trying to do and to seek their understanding and their viewpoints and what actually could be done so they know things can work in practice. We do things, as I said there, about specific sessions on key health topics. One thing we have done recently was we had, bless him, Pete Burnett. We put him in front of 70 chief execs across the voluntary sector last year and said, talk to us about the changes in the ICB. And to bless him, he came along to do it, knowing the fact that things were still changing within the Integrated Care Board, but came with a very candid and open, and it was very refreshing to hear, session where he could explain, this is what we know, this is what we probably still don't know, but here are some potentials of what we could to do with it. How do you see this working with us, and how can we take that forward? And Pete has actually offered to come back once the dust settles within the Integrated Care Board to bring himself and some of his team together to come and meet with the voluntary sector. We also do an annual conference every year. It's been moved, usually it's in September. It's actually taking place this year on the 24th of July. Currently we're sold out, 120 voluntary and community sector organisations attending with a range of public sector partners and colleagues. And we've got a great programme. We've got Jane Moore, Chief Executive of the County Council, as our keynote speaker to talk about changes across all departments that could be coming nationally and how that might actually then need to be taken forward across into local communities. We are also having a panel session which is called From Safety Net to System Partner, what should the voluntary sector's role in health really be in the future? And on that one, we've kindly had again Pete Burnett, but also Simon Pizzi from UHL, who have agreed to be on that panel with some key people from the voluntary sector. And we've had some great questions come forward, so I don't envy the panel on that one. But also, as I said earlier, we have now a CEO peer network, which I established, it'll be a year ago in July. And that now brings together 70, as I said, chief execs across the city and the county to talk about, you know, how we support each other, how we learn together and learn once, but also how we can have that common view and that common agreement and assessment on things that are going on that we know we need to get ourselves geared up for. Final slide, please, Abby. And then really just to explain a bit about some of the current priorities and challenges that we're doing. Obviously, as I said, neighbourhood working. I'm actually meeting with the admin on Wednesday. We're going to be chatting about the ICB's current plans around the voluntary sector and how can we together work. And then obviously from that, how do we shape it, take it forward and get the voluntary sector input into it. As I'm sure everyone around this table is really heavily involved in local government reorganisation. What does that look like? What will that mean? What happens to groups? You know, there's some of them are concerned about, you know, if I'm delivering specifically around particular health priorities or I'm funded maybe particularly from a district or borough council and it becomes a different authority, what does that mean? So we're obviously trying to work with that and having some great conversations behind the scenes to get things ready to start supporting the sector on that. As I said earlier, changes with the Integrated Care Board, the changes nationally happening with NHS England, and also the changes to come with Health Watch and the independent public voice. So we are everywhere and anywhere. We are basically where we can, challenging constructively, but ultimately it's about trying to make sure we can get the voluntary and community sector embedded into everything across the piece around health and wellbeing, so we can make sure that communities and their service users are either represented, having a voice, but also are communicated to about what's going on for them locally. That's what I really want to say. Thank you, Chair.
Thank you so much, Kevin. Any questions or statements? Okay, I'm just going to read the proposed motion just quickly. The board recognises the strategic contribution of VAL and the VCSE sector in supporting prevention, health inequalities reduction and community resilience, supports continued partnership work between statutory organisations and the VCSE sector via VAL, encourages stronger VCSE involvement with within neighbourhood health planning, commissioning and integrated care arrangements, supports ongoing collaboration between NHS partners, local authorities, public health and community organisations. All agreed? Thank you so much. And could we actually now go for a comfort break? Can we all be back at 4 o'clock? Is that okay? Yeah. Next one on the actual agenda is item 11. But because Michael Squires has a pressing engagement, I'd like to take them out of order. So I'd like to take a motion to actually change the order around 11 and 12. Is everybody agreed? Is that okay? Fantastic. I'll take that as read. So Michael, would you like to? Or John? Oh, sorry, John. Sorry.
Okay, thank you, Chair. Right, so I'm here today to give an update on the draft Leicestershire Carer Strategy. So I'm going to give a short kind of summary of the report and then welcome any comments from board today on the report, the action plan, the strategy as part of the consultation process. So the consultation formally ended yesterday. We've had a really good response to that and really good feedback around the three key priority areas that we outlined in the strategy. We did a session last week as part of Carers Week, which brought a number of carers together at County Hall, did some work around the strategy as well on that through workshops. Councillor Squires was there to give us support to that as well, which is really good. So this strategy is a Leicestershire specific strategy as opposed to LLR. The previous one was LLR. And we felt we needed to focus on Leicestershire, given the national focus on carers, our programme of work to support carers in the county, and the improvement areas identified in our CQC inspection, the council, and moving forward, CQC have identified carers as one of the key priority areas as part of the assessment process for local authorities. It's also an all-age carer strategy, so previous strategies are focused on adult carers. This strategy will focus on adult carers, young carers, and parent carers of children with a disability. So we've got really good engagement with our children's colleagues. They're fully kind of started on the process, have been involved in the consultation, and we've involved parent carers as part of that as well. A key part of that is also making sure that it aligns to the SEND strategy, of which we're kind of very mindful of as well. So just in terms of policy context, so we've got an adults and communities overall strategy, which is the 2025-29, and we've got the wider council strategic plans. This strategy builds on the work we have done across LLR over the past 3 or 4 years. And it also reflects our Care Act duties, the Children and Families Act and the Care Leavers Act, so the Carers Leave Act 2023. And it also supports the council's decision in, the December 25 council resolution to formally recognise carers, involve carers in shaping services and removing barriers and assessing impacts on carers in future decisions. Just a bit of context in terms of some of the numbers. We've got about 60,000 unpaid carers in Leicestershire. We as an authority complete about 1,400 carers assessments annually, and we've got about 2,500 carers receiving council funded support. In terms of young carers, it's 116 referrals and 69 assessments in 2025. And we've issued 341 young carers passports since 2022. And in terms of resources, adults and cultural services spend around 3.5 million on direct carers support services. And we commission Voluntary Action South Leicestershire to support carers across the county through information advice, general support groups, and they also issue carers passports as well. We've got a support at home pilot, which supports carers with non-regulated care through kind of sit-in services. We have a dedicated carers assessment team that sit within our directorate. So there's a team of care assessment workers that specifically identify carers and assess and review. And in addition to that, we do fund carers with short breaks and residential respite as well. So there is a menu there of services to support carers. We know that we need to, through the strategy, build on that, and through our own improvement plans, look at a wider carers offer. So in terms of engagement, from October last year to December, we engaged about 300 carers to talk around what they wanted to have in a strategy, what are the kind of the key areas they'd like to see. That's through one-to-ones, support groups, and also team sessions. And it's in the report. There's a few areas I'll just highlight, but there's areas around recognition, respite, young carer support, peer support, information advice, and loneliness. So they're really key areas that carers identified that they'd like to see in the strategy. We've then built on that feedback and identified 3 key priorities in the strategy. They're highlighted in the report. So that's number 1 is carers are recognised, valued, and listened to. Second is around information and advice, and thirdly, carers are supported with their wellbeing and access to services when needed. So the 3 priorities. The feedback we've had, the initial analysis that we've had, and the feedback to date is that those 3 priorities sound about right as part of the consultation process. So really, really positive feedback on that. As part of the consultation, we have engaged with parent care. As I said before, we've done a bit of work with our health partners as well to make sure that health actions and health priorities are highlighted as part of the strategy. So there's going to be some specific actions within the action plan that address some of those areas. And in terms of next steps, so as I said, the consultation is now closed, but I'm obviously happy to receive feedback today or even after the meeting from colleagues on some of the areas that you'd like to comment on. We are analysing the feedback that we've got. We'll produce a final version of the strategy and action plan over the summer, and then we'll collate that and have the consultation results and the final strategy presented to Cabinet in September 2026, hopefully for approval. And then following that, we will publish a strategy. And then that's just the start of the process. There's a lot of work then to do around actually what do we do, how do we make this a real live action plan? You know, what's the governance around it? How do we make sure it hits what we need to hit? And how do we continue kind of address the areas for carers as part of the carer strategy and wider thinking? So I'll end there, Chair. I know it's quite quick and brief, but if there's any comments on the strategy, if there's anything you want to raise, or as I said before, happy to take comments over the next couple of days from members of the board on the strategy and action plan.
Okay, keep going, Chair. Any questions, comments? Mr. Squires.
Thank you, Chair. Not quite a question, but a bit of a statement. In December 2025, the County Council recognised carers as needing particular consideration and support, specifically to ensure carers are consulted and involved in shaping services and to review all service delivery to remove barriers to carers. 2 months ago, in April, Cabinet agreed to launch a public consultation on the draft carer strategy, which closed yesterday. The new strategy aims to improve and strengthen support available to carers. Carers are the backbone of our health and care system. Every day across Leicestershire, thousands of people provide unpaid care for family members, friends, neighbours, loved ones. Their dedication allows many residents to remain independent, connected to their communities and living in their own homes. Yet, caring can come at a significant personal cost. Many carers balance caring alongside employment, education, family life, and their own health needs. Too often, carers put the needs of others before their own needs. This strategy recognises the immense contribution that carers make and the challenges they face. It sets out our commitment to ensuring carers are identified earlier, listened to, supported effectively, and given access to the information, services, and respite opportunities that are necessary. Our strategy crucially applies to all carers, including child carers. As Cabinet Member for Adult Social Care, I'm particularly keen that we continue to strengthen our partnership working across health, social care, voluntary organisations and local communities. Supporting carers is not the responsibility of any single organisation. It requires a joined-up approach across the whole system. And I'd like to thank all those carers in Leicestershire, wherever you are, and whoever you care for your commitment and dedication, which often goes unseen.
Thank you much, Mr. Squires. Please, John.
Thank you, Chair. Yeah, I just wanted to sort of reiterate some of those points, and something that Indy said. So, this has been a really good example of engagement in developing the strategy thus far. We have had a lot of engagement. We've had over 300 people who helped us with the draft strategy. We've had over 100 responses to the consultation. So it has been quite far reaching, and we have adapted as we've gone along. And I think we can and evidence that actually the strategy has been developed and is being iterated in line with the comments that we're receiving, both in terms of adult social care, but also children's services and health services. The couple of key things in here. The first is that priority one, which is about recognising carers. One of the biggest issues that we've had over the years has been how we identify carers and how carers themselves identify themselves. And that has been a real challenge, and it continues to be a challenge. But I think working with colleagues, particularly voluntary sector, going back to Kevin's report, there's a real issue about equity of access and to services and about equity of resourcing, I think, for carers, which is something that we will have to work much harder at over the next few years. Partly because we are clearly not hitting everything. It's 60,000 carers in Leicestershire, and we've got 2,500 on our books. We know that Basel have got 7,000 on their books. That still leaves quite a lot of people potentially not getting the support that they need. And it's particularly an issue in rural communities that we need to have a think about, but also in some of our other communities across the county. I think we support some communities better than others, is what I would say. The other issue is about information advice, and I think there's an issue here where we really do need to engage with people much more around types of information that people need and where people access information. We struggle, and if you look at some of the national data, we struggle in Leicestershire to engage people in a way that seems meaningful to them. So the feedback we get in terms of how easy it is to access information is and continues to be quite difficult and quite challenging compared to other areas. So I think there's something we need to think about in the strategy in terms of how we do that and the sorts and natures of information that we make available to people. Then there's a whole issue about services and the appropriate services for carers. And we will be bringing some further reports through the Health and Wellbeing Board over the course of the year about how we are developing our carers offer. Because not only are we developing a new strategy, but we've also got to go out and procure a new carers support service over the next 6 to 12 months. But equally, we want to invest much more in carer support. So we want to develop more support for carers. And we need, obviously, to do that as a system. So I think it's a really good piece of work and very timely.
Thank you, John. Thank you. Okay. Just a quick one, listening to what you're saying there, John. So just making some notes. I think this is a great, sort of what's coming out so far in the strategy, and also, like you said, the recognition and knowing there's that level of carers that aren't being reached. Is it something collectively then we may need to think about? How could we do something in light of the new neighbourhood arrangements? Because when I'm thinking about, we've got all these things waiting to come, we've got all this, changes and so forth. Once we know what that offer looks like, I wonder whether we could build maybe collectively across this partnership something in around how we're reaching out to the carers. So not only do they understand the new neighbourhood arrangements, but also maybe helps yourselves with regards to actually reaching out to find out a bit more, explaining what your strategy is doing, where they can get the help and support from. I think it might, maybe I'm being a bit too rose-tinted glasses here, but I think it lends itself to that might be an opportunity that we might want to exploit.
Kevin, there's Yasmin next and then Fiona. It's okay. And Matt.
Thank you. No, I think I really welcome the fact that we've got a place-based strategy for carers, and I think that's the right approach. I think that does give us an opportunity now, directly responding to the question you posed, Kevin, which is around the opportunities from a neighbourhood perspective. As we were talking, and John, especially when you were saying, I was thinking about from a health sector perspective, we've been part and parcel of that sort of carer strategy as well. I know we moved to a cluster-based approach in terms of our system, but certainly something through the neighbourhood work we can look at to make sure that we're not duplicating efforts, and where we've got health services, particularly general practice, that is coding carers, how do we share that data so that we have a much more collective understanding around those numbers as well? Because I'm sure that if we put all of that together, that number will be a lot bigger than what it is at the moment. And I think it enables us to start to really, bring out what that unidentified need is collectively from a carer's perspective. But I think it's a really good starting point that now we do have a more place-based strategy, because that enables us to focus at place and neighbourhood. Whereas I think previously trying to do it across the system as LLR, and understanding our populations and our communities are different, so the needs are different, and therefore we need to think about how we work with that differently than we have done previously. So I do welcome that, and I really support the fact that we've gone to a place-based strategy.
Thank you. Fiona.
Thanks, Chair. From a Health Watch perspective, we get regular calls from people who are undertaking caring responsibilities with all manner of issues. Most common ones are delays in accessing services, or delays in undergoing assessments for whatever services they may or may not be. Now, I think it's true to say that Health Watch recognises that situation is improving slowly. Ever since the CQC report had highlighted, there's been good action taken by the County Council, and that is definitely an upward trajectory. Having said that, there are a number of issues, I think, out in the communities in relation to, particularly around identifying who carers actually are and where they are, and John has highlighted that. A number of people, obviously, who are carers, looking after loved ones, wouldn't be eligible under the financial guidelines for support from the County Council. But what they do need is knowledge about what services they might be able to access, even if they're having to fund that themselves. And this is where the NHS comes to the forefront, because those people are more than likely to have spent time in a GP surgery saying, I need help as a carer and support as a carer, or I have a loved one who sat beside me who has some kind of illness. And there must be a way of joining up the information that's coming through to general practice with the facilities that we know that the County Council can offer, even for payment, and then trying to support carers in that respect. And the final point I will make, if I may please, from a Health Watch perspective, is that young carers, one of the aspects of young carers that Health Watch has come across is the interruption to their education by being a young carer. And I think we've mentioned that previously, but I think, again, it's just worth highlighting that aspect for members of the board, because it is an important part of the strategy to support the young carers in education as well as with the other aspects. Thanks, Chair.
Much, Fiona. Matt, please.
Thank you. Thanks, John. I want to build on some things that Fiona said, and I was mindful of in her report, there's actually a couple of quotes that come through about carers and what appears to my eyes to be something where they're not actually recognised, which is the point of this report. So the first requirement is let's recognise carers for what they do and who they are. And we've recognised that a number of them aren't visible to us. There's a kind of different question in my mind, which is, we're familiar with the notion of residents, and we have obligations, statutory obligations to the residents of our county. We're familiar with the notion of a patient, and within the NHS, I'm sure all of us are aware of the obligations, statutory obligations to patients. But with carers, it's in this sort of fuzzy area where, if I'm honest, it says there's the Carers Leave Act came in, and there's a statutory requirement for us to give 5 days unpaid leave to people who would seek it. I didn't know that's the first time I knew that. I'm not clear on the obligations, if I'm honest. But more importantly, I don't know that we would know enough in our many services for our people to recognise carers when they come in, because they don't come in with a sign saying I'm a carer. They might offer the information, but it's therefore something almost cultural in the approach that we get. And I think it's the question for me is, what is it that we could do to support our people to actually recognise the role, the importance of the role, and also the statutory requirements that we are required to ensure that we meet, because it's clear that through the reports that we don't. Thank you.
Thank you, Matt. Is there any more questions? Or thank you, Michael.
Thank you. Yeah, I think one problem that's quite difficult to overcome is that a lot of carers feel that they're not a carer, they're a family member. And there is a degree of truth in that. My question is to Yasmin, to ICB generally. If you've got patients or carers presenting at GP practices and you can code them as being a carer, how do you then get that information to us? Because I imagine that's going to be, in terms of information sharing, be quite difficult.
That's something that I'll pick up internally to look at what we can do there. There's got to be something that we can do, because this is about making sure that people get the support that they need. It, you know, impacts on them as individual, their patients too, and also the people that they're caring for as well. So there's a real importance in this, isn't there? So I'll pick that up internally to think about what we can do and how we can share that information, because it feels the right thing to do. It's probably just trying to understand how we do that through the, you know, the always interesting information governance rules that we abide by.
Thank you all. Any more questions? It's a very interesting topic, isn't it? I'm just going to, for the record, I'm just going to roll back a little bit. I'm just going to say, just for the record, that what we've just been talking about is for the people at home. The report seeks the comment of the Health and Wellbeing Board on the draft Leicestershire Carers Strategy 2026. And that's been introduced by Juliet Lahal, who is the Assistant Director of Strategic Services of the Adults Department at Leicestershire County Council. So the proposed motion is that the board notes the development of the strategy for carers in Leicestershire and the draft priorities and implementation plan, and B, officers be requested to take note of the comments now made on the draft strategy for the care and support of Leicestershire carers. All agreed? Fantastic. Thank you so much. So rolling back now. Thank you so much, India. Mike, thank you, John. Back on to item number 11. So we're now moving on to the Health Watch Leicestershire report, Improving Hospital Discharge. So this report presents Health Watch Leicestershire's findings from 2 pieces of work on hospital discharge, and Fiona Barber, Health Watch Vice Chair, is going to present this report. Thank you so much.
Thanks, Chair. Thanks for the introduction. Colleagues around the tables will be aware that under the 2012 Health and Social Care Act, health watchers are required to carry out entry and view visits to both health and social care premises, gathering views from members of the public who use health and social care services, and also for us to assess the standard of local health and care provision with a view to making recommendations for improvement based on the views of those service users. Today, on behalf of Health Watch, I'm pleased to share with the board 2 of its recent reports that have focused on discharge. We've already touched on the subject of discharge today, particularly around discharge delays, but these Health Watch reports are looking more broadly at people's general experiences of their discharge, not primarily at the reasons for any delays, although I will mention the word delay later on. The 2 reports are an entry review report we carried out in March of this year on 4 wards at the Evington Centre, Colville Community Hospital and Loughborough Hospital, all hospitals managed by Leicestershire Partnership Trust. We also published a service report last November around improving hospital discharge, which followed on similar work carried out in 2019 and 2020. This relates to discharge from UHL hospitals, acute hospitals in the city. I should say at this stage that the feedback we got from patients and carers, feedback from city and county residents, because of course all the hospitals are based in the city, all the acute hospitals are based in the city, whereas the hospitals managed by Leicestershire Partnership Trust are outside in the county. There are also some of the feedback you'll see also relates to patients who have used hospitals. They are city or county patients who have used hospitals outside of the county. So George Eliot, maybe Kettering, maybe Peterborough. So that's inevitable when we're carrying out a large scale survey. So before I talk about the reports, if I may, I thought it'd be worth reflecting on what good discharge might actually look like, and also thinking about who may be involved in planning and supporting the discharge of the discharge process. So initially you have the patient, which hopefully is at the centre of all the thought and planning going on, and then you have family of the patient, probably, maybe a carer or carers at home. You have the medics involved in their care, getting to a point where they're medically fit to be discharged. You may well have people from social care who are involved in planning for when they come out of the hospital and what services they may need at home, maybe some reablement, maybe some just general support. You have the voluntary sector who are sometimes providers of those services or who will check up on people when they come out of hospital. You have neighbours who may be involved in supporting the people. So discharging one patient can involve a whole team of people, hopefully working in partnership. In general, the process of planning by hospitals would begin as soon as the patient is admitted. The aim would be a safe, smooth and fully supported transition from hospital back to wherever the patient calls home. The patient should be leaving with a clear understanding of why they were admitted and what their current status is. A complete list of new and continued medication, including how to take them and an adequate supply, perhaps up to 7 days worth. The primary point of contact going forwards would be, is it the hospital, going back to the hospital? Is it the general practice? And should know about any necessary follow-up appointments. They'd also hopefully have some specific instructions on any restrictions for them, given whatever they've been in hospital for, any physical activity, red flags to watch out for, plus any specific nutritional fluid requirements and so on. Patients, on the other hand, want to have a feeling of being supported. They want to feel involved in the planning for the discharge so they know what's going on. And more importantly, they want to feel supported throughout the discharge process. Earlier this month, I presented this report to the Health and Communities Overview and Scrutiny Committee. I went through the report and highlighted some of the issues and some of the recommendations that Healthwatch had put forward. Committee members then spent the best part of an hour echoing the findings of the Healthwatch report and talked about similar comments from residents they represented, particularly in relation to communication with patients and medication readiness. And I say this not to highlight it, but the fact that the elements of discharge that Healthwatch found are recognised by the people in the community on a fairly regular basis. And if you talk to anybody or any groups about discharge, they're going to come up at the moment with fairly similar experiences. And I will say that in a previous life, I was involved in a Healthwatch, as a Healthwatch rep on a discharge steering group where we were looking under the guise and leadership of UHL about how to improve the process of discharge. Lots of really good recommendations were made. Most of them were put into action. But as we know from the statistics, the art of discharge is really complicated and we're not seeing hugely improved metrics even now, some years later, despite all the work that went on then and is still going on now. So in terms of the reports from UHL were mostly based on the results of a survey undertaken by patients and carers. as they were being discharged or had recent discharge. It was an open survey, so people could respond according to if they wanted to contribute their thoughts and feedbacks. So there are in the report, with the paperwork here, you will find on page pack 137, paragraph 12, the key findings. There are lots of positives to take from the findings. So 58% of respondents felt involved in discussions about their discharge. 71% received a copy of their discharge summary. 60% were discharged within the time frame they expected. However, that's all the positive side, really nice. And one of the key elements that most of the people completing the survey highlighted was the kindness, professionalism, and compassion of staff. Only 46% rated their hospital discharge experience as good or excellent. So that gives us an idea that more than half of the people that we surveyed, and that's a small number compared with the number of patients that UHL discharge every day, never mind every month or every year, only 46%. So that gives a flavour that there is further work to be done. Healthwatch always puts in a summary of recommendations attached to the report. Recommendations for UHL focused a lot on processing, communications, making sure that patients understood what was happening, what was getting clear information, perhaps further training for staff. 10 set of recommendations, which were there, we hope to be helpful and give some thought to people at UHL who wanted to improve. In terms of the wards with the community hospitals supported by Leicestershire Partnership Trust, there was a far more positive aspect there. There was comment on how calm the discharge process was, how calm their stay was. Strong multidisciplinary working, really clear patient satisfaction. So you've got a clear difference there between the acute hospitals where discharge is much more urgent. It has to be done in a timely manner so that the beds can be ready for the next patient coming in at constant throughput. Whereas the community hospitals, it was a slower process, more involved process. And I get that just really reflects, I think, the different aspects of the different elements of care at those stages. The recommendations in terms of the community hospitals, a lot were around the facilities. There was still some element where Healthwatch felt that based on the strong examples they saw of promoting independence, meaningful activity and coordinated discharge, there should be planning by sharing that good practice across all the discharge wards, not keeping it so tight. And Jean, you mentioned mental health discharges earlier. If there's a piece of work that you would want to commission Healthwatch to do before it ends at the end of March, then we're more than happy to have that discussion. But having said that, in terms of the general report for today and the Health and Wellbeing Board, I think it's really a recognition of where we are with the discharge process. There are lots of good processes there, but it is an area where some communication, some calmness and some thoroughness would be of benefit. And anything that can be done to improve the timeliness of the medication element would be welcomed by patients, because that's been a constant thorn in the side for years. And I know the pharmacies and the planning have looked at it time and time again, but it is still causing delays and dissatisfaction for patients. So, Chair, I hope that's a very quick romp through the reports. They're both available, as I said, on our webpage, and there are links on the report on page 138 of the pack, which would take you straight to the Healthwatch reports, should you have a mind to go there. Welcome any comments or thoughts through yourself.
Thank you very much, Fiona. Ashley, would you like to come back for UHL?
Sorry, rolling a miss. Yeah, thank you very much for that. No, I thought that was really insightful. Yeah, I've noted down a few of the key stats. Obviously nice to note the positives, but the fact that only 16% felt informed of their right to a carer's assessment and sort of yeah, some of the key highlights like that, I need to feed back to the team. We do have a quality strategy in UHL, which has quite a strong focus on carers, and we're doing like an annual review of that currently. So it's a good chance for us to make sure that it's aligned with previous report and their experiences in terms of discharge. But more generally, I think similarly, pharmacy colleagues, as you alluded to in the trust, they're very focused on this area, medicine optimization and reducing wastage as well. So yeah, I'll share these findings back along with the recommendations. I'm not sure how sort of many of my colleagues will be aware of the recommendations from the report yet. So certainly we need to do a bit more sort of awareness raising of that and take forward some actions from it. But thank you.
Thank you, Ashley. Ed.
Thank you, Chair. Yeah, I mean, I think Ashley just picked up the point I was going to make actually was around accountability in terms of learning from this, because there's some really interesting data, isn't it? And it's not just the preserve of one agency or organisation. There's a system that will include multiple partners. So I guess, I'm just looking for a bit of clarity and assurance about how we make sure this doesn't go on a shelf and is something that was helpful once, but actually is used and actually there's a product and an outcome and a response to it. And then that potentially comes back to this board at some point as well. Thank you, Chair.
Thank you, Ed. Mr. Golfan.
Clarity of your report and the interest, but your final comments in particular. Getting out of a hospital takes hours. They seem to have invested a lot of money in discharge lounges because they know how long you're going to wait. And time after time, there have been people that I've known have been ready for discharge and you've been hanging around. And that, I think, there has to be a better system. And also we've had relatives who have been discharged from hospital, and the first thing you've had to do is, for some peculiar reason, have to go chasing around to a local chemist because for some reason you can't get whatever it is in particularly in the Royal. I recall one occasion because the local pharmacy in the hospital doesn't stock it, but carry on the good work. Thank you, Chair.
Thank you much, Ms. Golfman. Does anybody want to come back on what Ed was saying? Sorry, you're out of my eyesight, aren't you? Yes. Hello. Sorry.
So Fiona, thank you so much, and thank you to colleagues in Health Watch for the report. We have discussed that from the Leicestershire Partnership perspective in our Exec Management Board, and we provided updates, and we're regularly reviewing the actions relating to that. Just for clarity, it's that they are rehab wards. We've got a mixture of rehab wards and stroke wards, and not discharge wards. Although some of them are used for discharge to assess. In relation to the comment around the discharge piece in its entirety, there is a piece of work that has been undertaken in conjunction with the Leicestershire Partnership Trust and UHL, looking at the discharge process and how it can be improved. It's been recently taken over by two of the heads of nursing, so they're really looking at it from a quality perspective. So I'm hoping that there'll be some movement from that, particularly around how we can move some of the things forward. The other thing just to mention as well is that we did do a piece of work a couple of years ago on the stroke unit, didn't we? A quality improvement piece at UHL, and that looked very much at how we can improve the timeliness of the medication. I think we're going to loop back round and look at some of the recommendations from that, because I think that made a massive difference at the time. So really always appreciate Health Watch coming in and doing their interim views. So thank you, Fiona, and I have said thank you to Harsha, and I've also taken her up on some of the offers in terms of before you go. So hopefully we'll be able to get some of those in from mental health wards as well. Thank you.
Thank you, Jean. Ed, would you mind just for my benefit restating your point, because I feel that somebody might want to come back on that.
Yeah, I mean, I was just making the point Ashley was referring to perhaps the lack of visibility there was at this point on the findings, and clearly there's some important messages there. And I guess if this work is going to have value, it's important that the relevant agencies have sufficient oversight and then collectively have an accountability to respond and learn. And that's when this information is going to be productive. So I guess it was just, are we clear on the mechanism by which this information is disseminated and then owned by the relevant organisations who have some responsibility for responding?
Okay, thank you. Yes, sorry, Yasmin.
Yeah, what I was going to suggest is make sure that this report, I've made a note to check back to make sure that it is part of the strategic discharge group, which both UHL and LPT are key strategic leads and partners in terms of that work, and which is what the work Jean was referring to, that the two heads of nursing are leading through that group. So what I'll make sure is that the report is tied into their work programme, because that's, from a governance perspective, really where it needs to sit, because that group is really what has got the instruction of improving discharge and taking that strategic approach. So I'll make sure of that as an action to make sure that that is picked up through the heads of nursing and the strategic discharge group.
Fantastic, thank you, Admin. John or Mark, have you got anything to come back on there, or are you happy?
No, that's perfectly fine with Yasmin's suggestion. It's the strategic discharge group that's responsible for overseeing the operating procedures around discharge. So that's absolutely the right place.
Fantastic, thank you. Is there any more questions? Okay, thank you. So the proposed motion here then is the notes, we notes the findings and recommendations from Health Watch Leicester and Leicestershire's hospital discharge work, support system partners to consider how learning can inform ongoing discharge improvement, patient experience and inequality reduction work. And C is notes that Health Watch Leicester and Leicestershire will continue to gather patient and carer feedback to help assess progress over time. Are we all agreed? Fantastic. Thank you so much. Thank you, Fiona. Right. You're talking on this next one, Mike? Yeah. Okay, fantastic. Okay, I'll on to item 13. Our final report is the Health Protection Annual Report. This report provides an overview of health protection activity in Leicestershire from January to December 2025. So Andrew Patel, Strategic Lead, Health Protection, Leicestershire County Council, will present this report. Thanks so much.
Yeah, thanks, Joe. Just before I hand over to Anuj. So just remind the board that we do an annual report on health protection, recognising that protecting ourselves against threats and hazards to health is a major part of public health, and also forms one of the things that I think the Health and Wellbeing Board should be interested in. So we do put it by way of an annual report. Given time, I'll hand over to Anuj for a little brief summary of the paper.
Thank you. So the Health Protection Annual Assurance Report provides an overview of health protection activity covering the period January to December 2025. The report supports the statutory duties of the Director of Public Health, and it summarises performance, significant incidents, emerging risks in key areas that require ongoing assurance. Overall, the report provides a position of assurance. During 2025, Leicestershire did not experience any sustained large-scale health protection incidents, but the year still required ongoing vigilance, responsive partnership working, and system oversight across the full range of health protection responsibilities. The report covers the main domains of health protection, including infectious disease control, immunisation, screening, sexual health, TB, healthcare-associated infections, emergency preparedness and response, and air quality. In the section on communicable diseases, COVID-19 activity in Leicestershire remained low for much of 2025. There was a small autumn wave from late August that peaked in early October, but that reinforces the continued importance of surveillance, infection prevention in those higher risk settings, and the importance of the booster vaccination uptake in those eligible groups. For measles, national activity reduced compared with the previous year. Locally in Leicestershire, we had no recorded measles outbreaks, but there was enhanced surveillance and outbreak control measures were in place as needed. The report also notes the continued preparedness for other emerging risks, such as Mpox, and there were local action cards, pathways, and vaccination arrangements in place should escalation of that be required. The report also notes that pertussis activity in 2025 was substantially lower than the previous year, where we saw heightened activity, and the prevention of severe disease in infants remains important, particularly through the maternal vaccination and timely infant immunisation programmes. Moving into the immunisation section, the headline message reflects a good overall position. Coverage in Leicestershire remains above the England average, but it's clear that this should not lead to complacency. There's a continuing downward trend in vaccination uptake, which is reflected nationally, and our priority is to reduce the variation and inequalities in uptake. The report also highlights the HPV programme continues as a single dose programme. Coverage remains lower than pre-pandemic levels. The flu programme is strong. It showed stronger performance in older adults compared to the under 65 age group in the clinical risk cohorts, and also in the pregnant women programme. A particular priority identified for this current year is the maternal RSV programme, which requires improvement. It's a slightly newer programme. The report sets out an explicit objective to increase uptake to 60% through targeted outreach work. On screening, there's a bit of a mixed picture. The report notes that breast and bowel screening coverage are improving over time, and that's consistent with recovery efforts, while cervical screening is trending downwards across all age bands. The report also flags the importance of maintaining equitable access and ensuring strong governance in light of the proposed future delegation of vaccination and screening commissioning responsibilities to the ICB. For sexual health, Leicestershire's rates for syphilis and gonorrhea are lower than England, and we also noted that Integrated Sexual Health Service moved to a new provider from the 1st of April last year. There is a high HIV late diagnosis rate, which supports continued work to increase testing and promote earlier diagnosis. For TB, we know that it remains an important health protection issue. The rates in Leicestershire are generally below the England average, but the burden is unevenly distributed, and it's linked to wider factors such as deprivation and inclusion health groups. The priorities for 2026 include early recognition and referral, timely latent TB infection assessment and treatment, and targeted approaches for higher risk groups. For healthcare associated infections, the report notes that although local thresholds were breached for some organisms, as a system were not considered an outlier against overall national and peer comparators. It also highlights that ongoing infection prevention activity and the development of a local LLR outbreak framework strengthens local assurance and clarifies response arrangements. For emergency preparedness, resilience and response, the County Council is a Category 1 responder, and our arrangements are supported through the Local Resilience Forum and Local Health Resilience Partnership. We took part in a number of pandemic preparedness exercises during 2025, which the board has previously been updated about. And then finally, the report includes air quality as an important health protection issue, describing poor air quality as a major environmental risk to health, with impacts across the life course and inequalities in exposure and harm. The local air quality and health needs assessment is referenced, and the 2024 to 28 partnership action plan, including work on planning, travel choices and improving public information, is listed within. So I think in summary, there's a report showing the assurance that is received and then the priorities that we're focusing on for the current year. It shows that the local health protection system remained active and responsive during 2025 whilst identifying clear areas of focus. And the board is asked to note the annual report and recognise that the key health protection issues that arose locally, the actions taken in response, are the main areas of focus for the year ahead.
Thank you. Mike, would you like to say? Yeah, just to reiterate what Newt was saying, I was just thinking actually there's quite a lot of that has been in front of various health scrutiny committees as well, isn't it? So we recently, last Monday, took the Air Quality Partnership Action Plan to the Environment Flooding Scrutiny Committee, which was well received. Late diagnosis for HIV, I was just going to, it looks bad, but I know that was picked up on the performance report by HOSC and I'm looking at Anuj, hoping to fill in the gaps. There were good reasons why. It was explainable, I think, in terms of things to do with the system. And I really do forget not for what they were. I don't know if you got it to hand in terms of what the issues were around HIV late diagnosis.
No, sorry, I haven't got the additional context.
Thank you so much.
We could stick that in the notes just to reassure Health and Wellbeing Board that you know, it does support a focus on earlier diagnosis around HIV, but there were some kind of system issues which meant it's one of those ones the figures weren't as bad as what you'd think, if you believe that.
Thank you, Mike. Is there anybody else any questions or comments? Okay, well, moving on. So again, the proposed motion then is that the board A, notes the annual health protection report, and B, recognises the key health protection issues that have arisen locally, the actions taken in response, and the main areas of focus for 2026. All agreed? Okay, thank you very much. Before I'm nearly there, I won't keep you too long because it's been a very interesting and informative meeting. Everything that's going on in the council and everywhere else is an enormous amount of work. But for me, I just jotted down a few things that are key headlines that have come out today. I think is that we've got 1,241 residents supported through the Work Well Employment Programme. 108 vulnerable households received energy efficient improvements with 5 million secured for housing improvements. 69 housing repair interventions completed and 58 housing related health cases fully resolved. 84.2% annual health check coverage achieved for residents with learning disabilities. More than 350 health checks, workplace health checks delivered, and over 50 mental health first aiders trained. More than 1,400 volunteers actively supporting communities across Leicestershire. Cancer screening vaccination performance remains above national averages in most categories. And lastly, adult smoking prevalence reduced to 7.4%, significantly below the national average. So, well done, guys. Okay, so going on to 14 then, the date on the next meeting is of the the Health and Wellbeing Board will be held on Thursday, the 17th of September, 2026 at 2 o'clock. There are no other items that I consider urgent, so I now draw this meeting to a close. Thank you so much for your attendance. Have a safe journey.